And even when something unfortunate happens, we remain on the same page. We want to see them through. We want to fix them. Of course, if that adverse event has resulted in death, then that's not possible. But then we owe the family, we owe the people that have succeeded the patient, we owe them some kind of an explanation so that they can get closure. And often this is what the patient really wants. If you dig into patients after they have been involved in an event, they don't talk primarily about money. They talk about closure. They want to know what happened. They want to know why it happened and what the next step is. They want to know that there's some degree of accountability in doctors. And they want to know that we're learning from our mistakes, that these mistakes are not going to affect other patients, that retraining will take place when that's required. So, what are the patient's options for recourse when they encounter an adverse medical event? Typically, there are three pathways, and these are separate pathways which normally flow sequentially, but can flow concurrently. So these can all happen at the same time. Typically, after the event, there is some kind of a professional process, an inquiry, a complaint, a question and answer session, and sometimes it triggers a formal inquiry, which usually falls under the gamut of our professional regulator, the Health Professionals Council. Then, and not always after that's concluded, but often once it's concluded, if there is found to be some degree of negligence, then a civil claim is instituted. And this is basically a private way for the patient to seek some kind of compensation from the people responsible for the error. Of course, some errors have no particular person responsible. It's just something that can go wrong, as in a complication. And some are multifactorial. And so it's not always as easy to figure out who exactly to blame. And finally, and very uncommonly, although we are seeing this more commonly, are criminal charges. So what are we aiming for? Basically, we're aiming for a safe, error-free environment. We want patients to be able to not have any complications. We want everything to go according to clockwork. That's the perfect world. Unfortunately, that's not the world we live in, and you'll see why just now. If that does not happen, if there is a complication, an adverse medical event, what people used to call medical misadventure, then we want patients to be able to have access to the appropriate treatment and, if it's necessary, the compensation for their injuries. We need a system, ultimately, that fosters closure for the patients, that fosters accountability in doctors, and again, that fosters learning from mistakes. So let's recap. What are the problems? What is the extent of the problem? And I'm going to talk about this now. First and foremost, we have seen over the last few years how compromised the doctor-patient relationship has become. And this is for very many reasons, but primarily it's a capacity problem. If we had all the time in the world, we would be able to be as thorough as possible, we would make far fewer mistakes. But we're all under pressure. The public system is under pressure because it lacks the resources. The private system is under pressure because it's constrained by the funding mechanism. So you've basically got to make your time valuable. Secondly, there is no clearly defined patient complaint pathway. So yes, there's recourse with the Health Professionals Council. Yes, you can report a problem to the manager of a facility, or sometimes that's the person that's been responsible for the problem, to a hospital group and the like. But there's no clearly defined singular patient complaint pathway. And the legal framework is really problematic. Ultimately, when something goes wrong, it's a systemic problem. It's often not just one thing that went wrong. So how bad is the problem exactly? To err is human, and there is a book written in 2000 that sheds an incredible amount of light on this. Basically, the book was based on the findings between two separate studies done in Colorado and Ohio, and another study done in New York hospitals that showed that medical error and adverse events are uncomfortably frequent. These things happen incredibly more often than we would like to admit. They found that between 2.9 and 3.7% of all admissions experience some kind of adverse event. Just process that. 3%, 3 to 4%. they found that of those that experience an adverse event, between 6.6 and up to 13.6% of those resulted in death. The patient died as a result of that event. And they found that about 50% of them were plain, simple, and utter mistakes, not complications. A separate study done and published in the British Medical Journal was a study coagulating 8 studies put together, basically looking at 75,000 patient records and looking at the clinical records and what had happened. And they found that 9.2% of these admissions had an in-hospital adverse event. Just imagine that, 1 in 11 patients. And that the preventability was up to as high as 43.5%. So again, almost half of these patients, these errors could have been prevented. Fortunately for the patients, more than half of them resulted in no or very minor disability, 56%, but 7.5%, 7.4% of these errors were lethal. They killed the patient. The most common problems were about 40% due to operations, and 15% of these errors were medication errors. These are all completely preventable. So the result, of course, is that we landed up with what's become a litigation circus for lawyers and insurers. It basically has created an entire industry out of this medical misadventure. And as a prominent orthopedic surgeon in the UK said to me, unfortunately, it's in no one's interest to stop this system. Or is it? Actually, if you think about it, it's in our interest, and it's most definitely in the patient's interest to stop this system. As doctors, we often pay huge amounts of money to insure us against medical malpractice. A small amount of that money ultimately reaches the patient that's been the victim of those misadventures, and a huge chunk of the money gets used up between the insurance companies and the lawyers. There is also a problem in the whole legal framework. In most countries in the world, this system is adversarial, automatically pitting patient against doctor. Who created the problem, and then they must pay. They must somehow compensate the patient. Of course, this in our own particular setting has not been helped by the regulator. The Health Professionals Council has for some time been accused of being quite dysfunctional and very tardy. Very seldom do they offer the patient the closure that they are looking for. Ultimately, this all leads to unhappy patients. So what happens after a medical misadventure? There is no standardization of complaints pathway. There is differing advice given to the doctor who is responsible or who is involved or who is in charge of the patient's care. Differing advice coming from the insurers versus the profession itself. There immediately is set up a situation of divide and conquer. And of course, that's not good because it puts the facilities where these errors take place against the doctors who work in those facilities, and that's really not good. And ultimately, it's not good for the patient at all. And the ultimate result is that the patient is left again without closure. Sometimes they are left without a decent result, and sometimes they are left with inadequate compensation. So, are we our own worst enemy? What's happened to medicine? We really need to ask some philosophical questions here. We need to dig a little bit deeper into what's going on with us. Many years ago, maybe not that many, 20 or 30 years ago, medicine was a very highly respected profession. Doctors had a high standing in society as ethical, honest people. Why is that no longer the case? Why are people questioning our decisions and our advice so frequently? We've seen this classically throughout the coronavirus pandemic. Are we our own worst enemy? Is this because of the lack of transparency coming from the medical profession? The fact that we don't admit how often we don't know the answer? The fact that we don't even have clear statistics on just how good we are or aren't at treating something? Do we lack honesty? And of course, with the advent of the internet, people have access to information that's far more ready than it was in the past. Google Docs has become a thing. And so the problem, of course, is that you land up with memes like this. Please do not confuse your Google search with my medical degree. But of course, there are flip sides to that coin. patients sometimes understand much more about their condition than we do. Certainly they understand the subjective side. And what ends up becoming our role is not always to give them information anymore, which they often have. It's to help them contextualize that information and to help them make a diagnosis, because as we all know, self-diagnosis is not necessarily the case. Of course, there's a degree of media culpability here, and I think in the public there's a degree of schadenfreude. They actually, the media and the public, like to see someone successful with a good standing go down. This is bad for us. Bad news sells, sensationalism is destructive, and ultimately we get alienated by the media. This is not good. How many articles have we seen? How many newspaper reports, television programs? There's even a series called Botched. The name implies the answer. We need to work against this. We need to reclaim some of our space. Of course, accountability is paramount. We cannot step back and not take accountability. But there are many different spheres to this accountability. In the UK, they distinguish between negligence and gross negligence, and this is very important. Maybe there needs to be a second, third, fourth, and fifth degree of negligence. Clearly, there's a difference between forgetting to prescribe something and amputating the wrong limb. These are massively different things. Peer review systems, these need to be done by the people who actually really are important, who can work out what it was that went wrong and implement that change that is necessary. It is no good that a panel of general practitioners looks at what went wrong in an orthopedic surgery and try and figure out how it went wrong. And even worse still, which is the problem with our Health Professionals Council, that a panel of accountants and lawyers look at the same thing. They're even less able to understand the management. Maybe we need to move towards a system where we have a safety management system, things that look at the kind of Swiss cheese process and try and put it in these different slices so that the patient doesn't fall through lined up holes. The aviation industry is really the way forward in this, and we need to close the loop and implement change. So ultimately, what are the recommendations? How do we fix this? I have 4 simple suggestions. I'm not saying that these things are going to be easy. This is going to require massive systemic change. But here are 4 recommendations that really can massively change this space. We need to create a no-fault compensation fund. We need to stop blaming people because that doesn't fix the problem. We need to work out what the patient needs. We need to explain to them what went wrong or to their relatives, and we need to make sure that they are taken well care of after this. Undoubtedly, the world pinnacle of this is the New Zealand Accident Compensation Corporation. It was started in 1974, and there have been a whole lot of changes, but since 2000, they have incorporated medical misadventure, which is now referred to as adverse medical events or medical injury. It's a separate department of this corporation, and the patients are taken care of. We need perhaps to create an independent patient complaints agency. Patients have no voice, they have no recourse, they don't know who to turn to. They turn to our regulator, whose job is to police, and they often get a response, no, we cannot find any culpability or liability here. That's not an answer. They need to be able to communicate transparently and bilaterally with the team that was responsible, under whose care they were when this misadventure took place. We need to formalize our peer review processes, and this needs to be done under the banner of the Medical Association. We need to lead this process under the specialist societies, under the societal groupings of general practitioners, and we need to look after our own colleagues. We're the only ones who can really independently work out what is a good result, what is a bad result, what is acceptable, what is unacceptable. What do we do with a colleague that's made the same mistake several times? Can we retrain them? And so on. And finally, we need to make mediation mandatory. We need to stop fighting with each other. We need to sit down and discuss what went wrong. We need to be able to sit, even if the lawyers are involved and the insurers, but that industry might die if we actually get this right. We need to be able to sit down with the patient and or their relatives and explain exactly what went wrong. If we do that, we will stop the complaint system that's resulting in people trying to get doctors jailed for making a mistake or having a complication, which is something that can happen to any single one of us. I thank you very much.
Good morning, everyone. I think we've just had some wonderful presentations there from our speakers. Allow me just to introduce them once more. It's Dr. Graham Howard from the MPS. It's Advocate Matibi from the Special Investigations Unit, and our very own Dr. Mark Human with a very powerful presentation there at the end. He's the chairperson of the HRLE committee. Guys, we've heard a number of perspectives there. Let me throw it over to you, Dr. Howarth. The MPS have been very vocal on this criminalization issue. What was perhaps some of the recommendations that your organization has in this regard, or issues that you would perhaps like to see change?
Thank you very much, William. I think the problem for us, and I think firstly let's put it forward that these criminalization of doctors, they are rare events, to be quite honest. There's probably roughly 1 million doctor-patient relationships or interactions a week. And we see maybe 1 or 2 cases where doctors are charged either with culpable homicide or murder a year. So they are rare, but they are devastating for those people that are involved. It's interesting that Mark was talking about accountability and the importance of accountability. And yesterday I was speaking to the surgeons and my lecture was responsibility, accountability, liability, culpability, and punishment. And the real question is, I suppose, that has to be answered is, if a doctor plays a role in a patient's death, when are they morally responsible and should be held accountable? Now, the problem with the threshold for criminal accountability in South Africa at the moment, it is at the level of negligence. Now, if you look at the definitions of negligence and you read into the philosophy about holding people liable for negligence or culpable or blameworthy for negligence is probably the best way of putting it. I think the first thing that is clear, and Mark made very clear, is that things go wrong on a daily basis and a multitude of times. It's almost part of the human condition. Medical negligence, when the doctor is negligent, that's inadvertent. They don't do it on purpose. It's an oversight or something that happens. So it's not something that you do actively, and yet you can be held criminally liable for that mistake. Now, let me give you an example of what could be held to be negligent. I mean, negligence goes around, what would a reasonable doctor done foreseen under similar circumstances, and what would they have done to stop the outcome from occurring? An idea about the prevailability of negligence, the prevalence of it. All of us have been on Teams calls where we've been muted and then started to speak and we're still on mute. And someone says, in fact, I think it's a sort of saying of the year, or if not the decade, oh, Graham, you're on mute. Volker, you're on mute. William, you're on mute. We've all done it. Now, we know it's foreseeable that if you're on mute that you won't be heard. So that's the sort of oversight. That's an oversight. That is basically fulfills the criteria of negligence. And it just seems to be so low and so unreasonable. So I like, along with Mark, the idea of at least gross negligence. So really, how would we define gross negligence for the jobbing practitioner, the doctor on a daily basis? It's almost, in my job, I see things and I think to myself, goodness me, as a clinician, I could have done that. I understand what went wrong there. Gross negligence is almost, you look at it and think, Neerbut, I could never have done that. This is so far from what I anticipate as proper medicine. There, a doctor maybe should be held culpable. So I think at the very least, gross negligence. Possibly we could go to the Scottish level where there's recklessness, where there's a subjective foreseeability of the outcome. So you subjectively see, you realize that the patient is at risk of death, you realize that you're putting the patient at unreasonable risk, and you carry on nonetheless. Now, the closest one comes to that, I guess, in South African law is dolus eventualis, and that's what's being used to prosecute a colleague with murder in South Africa at the moment. And it just seems unfair. Murder, a doctor going about his daily duties. It's just, to my mind, almost inconceivable. So I think really, to summarize what we're doing, at the very least, we feel that the threshold should be moved from negligence to gross negligence, if not recklessness. There was success in New Zealand in doing it. Gross negligence is the threshold level in England and Wales, and in Scotland it's recklessness. So that's our main area of interest at the moment with respect to criminalisation, and in particular the idea of culpable homicide. Thank you very much for the opportunity.
No, thanks so much for that, Dr. Howard. I think that segues us nicely into our next speaker, Advocate Matibi. Thanks so much for the work that your organization does, rooting out corruption. I think because of all the corruption, it creates these systems that allow some of these errors to take place. And I think it's quite shocking, especially now during this COVID pandemic, some of the stuff that we've seen. I'd like to get a view from you. Of course, you spoke about the corruption in the healthcare system. Would you like to elaborate on some of what it is that we can do to root out this corruption? And perhaps if you've got a view on the criminalization of doctors when it comes to culpable homicide, if you're willing to share that with us as well. I know I'm putting you on the spot there. Please come in, Doc.
No, thank you very much for the opportunity. I mean, just to start off with your last view. I mean, the South African medical jurisprudence, in the main, has really been, based on the negligence that has been detected, on various processes that medical practitioners would undertake, specifically doctors, and of course the tests on determining negligence is different in the sense that the medical practitioner would not have intended that particular outcome. They would probably have done their best, but to a large extent the outcome becomes such that the patient or the family of the patient are ultimately not happy, and then there's processes and charges of culpable homicide. But I think well, the jurisprudence continues to develop in a sense that the best that the doctors can do, and of course they continue to do their best. It's really in circumstances where either they would, as I said, I mean, not really have intended, and then the outcome becomes that's not that pleasing to the patients, and more often. What we find in instances where there has been, a one report of the doctor setting out a certain set of facts relating to a certain patient, and if we have the reasonable apprehension that, there may have been some measure of misrepresentation, we would then seek, a second opinion from the panel of doctors that has been set up, and more often we find, a view that contradicts the initial one, and then we take it forward from there and interrogate on what basis was the initial report made. But I see I'm left with few minutes, and we see that a lot in the medico-legal space, where we are really active in investigating. I would have covered it in my presentation. The other misrepresentation that we see in the Health Professions Council of South Africa investigation is the misrepresentation by would-be doctors. And I use the word would-be deliberately because they end up not having the findings that they are really not qualified, and we end up with a lot of bogus doctors in the country, and you know what that means. When we've got the bogus doctors. But anyway. Generally, we receive allegations from the public, from the patients, from the medical practitioners, particularly in relation to the regulators, CMS, HPCSA, and so on. And then we continue to investigate. And our investigations picks up on individual medical practitioners, doctors in particular, and also service providers generally. So what we would like to do is that, the environment should be such that, and I had Mr. Human indicating that we need an agency where patients could have a voice. That would be very much welcome, because CMS at the moment has got a platform where people can complain, right? And I'm not talking necessarily, well, it would in the main be patients who have been, who feel they've been done in, from the medical aid point of view. So we require those kind of platforms to be made, available to patients. And our investigators are also out there. We have a platform where anyone can report, and we do our best such that we can investigate these allegations and hold everyone to account, including medical practitioners. Thank you.
Oh, no, thanks so much for that, Advocate Paturi. And I'm sure that SAMA will take up the invitation as well to join that panel that you alluded to. Right. And hopefully this is the start of many future engagements, and we can all do our part to better society by rooting out some of this corruption and ensuring that we resolve some of the other issues that we do face. And then we'll really welcome SAMA becoming part of the Health Sector Anti-Corruption Forum. Thanks. Oh, fantastic. Thanks so much, Advocate. And then back to Dr. Mark Human. An insightful presentation there, Dr. Human. I would like to know from you, could you perhaps elaborate on some of perhaps the main concerns about the criminalization of medical errors, and then some of these recommendations that you have had? I definitely think it's much needed that we look into some of them. What would be the way forward, and how can SAMA help to advocate for some of these recommendations?
Okay, so we'll start off with the criminalization side of things. Obviously, the net negative effect of finding doctors guilty of manslaughter or, God forbid, murder or anything like that is that people will stop doing interventional procedures because of the risks attached. So we'll become an entirely risk-averse profession, and the entire profession centers around a risk-benefit reward. I mean, technically, every interventional procedure we ever do on a patient is injuring the patient, but the usual laws of justice that surround that injury is that the patient consents to be injured on the understanding that we're trying to make them better. So we suspend some of the traditional laws that govern our society to make exceptions here. And this has to be borne in mind. It's hard to believe that any treating doctor would intentionally, unless they've got some personal or sidelined agenda, that's obviously a different thing, would intentionally injure or especially murder a patient. It's really inconceivable that anyone would go there. I mean, dolus eventualis is quite interesting, and I'm not a lawyer, but it's very obvious that if you fire a shot through a bathroom door, knowing that there's someone inside there, that you would know that you may kill that person. Whereas with dolus eventualis in medicine, every time we put someone to sleep, we know we might kill them. We're doing our best to keep them alive. Every time we operate on them, I explain to my patients frequently, understand that everything that I just did to you would have killed you if the anesthetist didn't keep you alive during this process, and so we have to take a totally different thought process and pathway to deal with these things. And of course, this is a collaborative effort. It's something we've been dealing with for a long time. SAMA's just recently formed a mediation unit. Gauteng Health's been dealing with mediation for a little bit longer than us, although it's a very slow process. But I mean, at one stage, they had 31 billion rands worth of outstanding legal claims. The tort system is horribly flawed. I mean, it's estimated that the tort system uses up 50% of the funds that are brought in for the administration and the lawyers. That means that only 50% is available to go to those patients who are injured. Whereas systems like the New Zealand system, which is far more, there's no litigation, and it's far more fair to the patient, it's estimated that 10% of the funding is consumed in administrative costs. and leaving 90% to go to compensation. Those are much better systems. Accountability is a whole separate discussion, and it's obviously a very long and lengthy discussion. You've got to have accountability, but your end result should not be trying to railroad people who've made a mistake out of the profession. It should be to try and prevent those mistakes, to learn from those mistakes, to inform the patient what went wrong. That's a really big failing that we have with our current system. And to institute measures, be they retraining, be they whatever, that prevent those mistakes happening again. So ultimately what we need, and this is why I said it's not easy. It's easy to make those 4 suggestions, but we need a massive engagement. So since about September last year, SAMA and the Human Rights Law and Ethics Committee has been trying to convene a big meeting between the NPA, the Health Professionals Council, the Department of Justice, the Department of Health, and doctors. Unfortunately, of course, every single time we get into the starting blocks, the next wave of COVID has arrived. So we got scuppered in December for the meeting we were planning on hosting in January or February. And then as we got closer in May, we got scuppered again by the 3rd wave. And so we're hoping to get this off the ground. But as yet, I don't think we have a date. But we obviously need all parties to engage, because this requires significant legislative and administrative change.
Yeah, no, thanks so much for that, Dr. Human. I think you're absolutely correct, and I think that brings us to the general Q&A session. We've, throughout the presentations, we've received some questions from the attendees. And let's start with this one from Dr. Lazarson. Thanks for the presentation, Mark. With respect to your 4 suggestions, don't they require buy-in from the state first? As without that, we will not be able to move from a punitive system to a system of acknowledgement, learning, and improvement of the system. Graham, let me throw that one to you, and perhaps then also to Dr. Human if you want to touch on it. So buy-in from the state if we want to move towards some of these less punitive systems.
You probably do need buy-in from the state. I mean, the present system is doubtless has a multitude of problems, and there's a lot to be said for mediation. It's a question that requires 2 or 3 days debate, to be quite honest, because there's pros and cons of all these things. No-fault compensation is a wonderful idea, but South Africa has a low tax base, of taxpayers, and if we're going to compensate everyone who is disadvantaged as a result of their medical care, then one of the problems there is, while everyone might get paid, a lot of people get paid a lot less than they might need. I think these are things that need much debate. I think there is general agreement, though, that the system is flawed and needs to be improved upon. And that's really why I'm really interested. And I mean, we're talking, when you're talking about the Lekgotla or the Bosberaad, we're talking about the criminalization issue. That's the sharp end of the problem. There's a much broader base, which I think Mark touched on admirably. And maybe it's best for him to, answer some of that question.
Over to you, Mark.
Yeah, so I think that there have been some steps in this regard. I know that the Law Reform Commission was looking at this some time ago. Unfortunately, the feedback that we've had recently is that it's been defunded significantly. And so obviously there has to be someone driving it, and there has to be funding, and there has to be an impetus. At the moment, it seems, I think the real impetus, the first thing that would really give us an impetus is forming a patient agency, because then suddenly this would give society, civil society a voice, which would apply pressure to the authorities to change this. Because as doctors, we've been talking about this for some time, and with not a lot of progress, because obviously there are significant reforms that need to take place. I think this meeting that we've been mooting is will be a big step forward, and I just hope we can get all 4 of those agencies to attend because that will make a big difference if we can openly debate a way forward.
No, certainly. And I think you make a good point there about practitioners and patients perhaps taking hands to the benefit of patient safety, and that perhaps being a driving philosophy around many of these changes that we want to see. Advocate Matibi, we've got a question in the chat from Dr. Cahud. Where should a doctor go if there is the threat of victimization, perhaps in exposing some of the rot and some of these practices that might even relate to state capture? Where can such a doctor go, and what protections are there for such a doctor if they want to expose some of these unfortunate incidents?
No, thank you for that question. In fact, we should have, put it in our presentation. But the doctor is welcome to report that to us, and by us I mean Special Investigating Unit, and we will make sure that it gets appropriate attention, including matters that may be pointing to state capture. And for purposes of this response, he can contact me, and I'll make sure that he understands the platform where he could report, or he could report directly to us. I'm at amothibi at siu.org.za. That's my email address, and if you need the telephone, it's 012-843-0034. Will be welcome to assist the doctor to ensure that any allegation that he has receives attention. Thank you.
Well, thanks so much for that, Advocate Matibi. That's certainly much appreciated. And once again, just thank you for the fight that you continue to fight to root out corruption in society. COVID has been a constant in all of our lives. We've got a couple of questions related there too. Let's start with the first one from Prof. Naidu. If a doctor prescribes ivermectin and doesn't do so through perhaps the Section 21 gateway, what are some of the issues such a doctor might face in terms of accountability and liability should such a patient pass away? Let me give that to you, Dr. Howarth. I know that the MPS has also given some guidance around this issue.
Well, I think ivermectin is an interesting and ongoing debate at the moment. As you will probably be aware, we had a webinar on it a month or so ago. With respect to the prescribing of ivermectin, there's two avenues available to practitioners. The Section 21, which was used to an extent, not that greater extent, I believe, prior to ivermectin being registered for other reasons in South Africa. Now it is registered, and it can be prescribed under Section 14, where the ivermectin is compounded. Now, the problems with the compounding is where the ivermectin comes from, and the compounding should be in response to a prescription for that particular patient. So there's a whole host of problems we think out there in South Africa with the lawfulness of a lot of the ivermectin that's available. So there's the one issue of the lawfulness of the ivermectin that the doctor will have been prescribing. And then the second issue really goes around to the issue of negligence, and that would be something that would have to be decided by a court, whether or not a patient or the doctor was negligent under the circumstances, and that would be dependent on the facts at the time. Now, conventional wisdom is somewhat skeptical of ivermectin, and the doctor may bear the consequences of that, and it depends to a large extent on expert testimony. And, that's why we're worried about the use of ivermectin. I think the safest way, if you are going to use ivermectin in South Africa currently, would be to prescribe within the ambits of the law. So that would be under Section 14. You'd use a compound medication, and the patient must be informed of the advantages and the disadvantages and the risks that they're taking. Firstly, by using a medication that is off-label, and secondly, by using a medication that is compounded. And our advice to a practitioner would be, with respect to that particular consent, it should be written consent, and it should be kept, so that if litigation or problems follow, then as Mark pointed out, expectation management and the consent process, one can't overemphasize the importance of that, particularly in a medication that is under such a dispute, if you will, as to its advantages and its disadvantages.
No, thanks so much for that, Dr. Howard. So certainly, please prescribe within the bounds of the law. Also on the COVID topic, Dr. Erasmus asks, what if a patient is given the COVID vaccine and passes away shortly after, and the doctor becomes aware thereof? What is a doctor to do in this regard? Who is responsible for determining whether that death is attributable to that vaccine? And where does possible compensation come into play? So on the last part, I suppose it would be the compensation fund that was established for that specific purpose. But Dr. Human, do you have some other insights into what a doctor should do if he or she becomes aware that a patient of his or hers unfortunately passes away after a vaccine?
The simple answer is no, I don't. I suspect that they need to contact the EVDS, or the advanced, the adverse reaction forum created by the government, because that's supposed to be centralizing all of this data. I think the biggest problem with vaccines is proving that the vaccine caused the death and not other things. The 6,000 odd supposedly vaccine-related deaths that they looked at in the States, they were unable to find a causal link between the vaccine and the death in the vast majority of them. So I think that's really where it gets tricky.
I think your gut feel is absolutely right. It does need to be investigated by them. And if it does come to compensation, of course, there will be a look into the causality thereof, and then claims would have to be put in against that compensation fund that was put up. I see there's a hand up from Dr. Howard there. Dr. Howard, please come in.
Well, I think it's a difficult question, but, going back to first principles, let's say one of our members phoned us for advice to say that they'd given the vaccine and the patient had died within 24 hours. I'd agree absolutely with Mark with respect to reporting along the correct reporting lines. If you are worried, obviously you run the risk of this being an unnatural death, and under the circumstances, I think at the very least, it would probably be prudent to speak to someone from the local forensic pathology services, so that when you do fill in the death notification form, if you fill it in as a natural death, then you can also say that you have spoken to someone from the local pathology services, forensic pathology services, and there's been consensus that it's a natural death, so you don't inadvertently fill in what would be maybe subsequently decided to be an unnatural death as a natural death.
If I'm not wrong, William, there also was, and this was a mandatory criterion from the vaccine companies, the creation of a no-fault compensation scheme around this. So there is already a mechanism for compensation for those patients.
Yeah, quite right, Mark, correct. Let's throw another question there to Advocate Matibi. You alluded to bogus doctors. What are some of the actions that are taken against some of those doctors? And then there was another question from Dr. Igaba about investigations in the private sector. We heard a lot about investigations in the public sector, but if you could perhaps elaborate on some of those as well.
Okay, no, thank you. The actions against the bogus doctors, we've received various reports of doctors practicing in various provinces, and we of course investigate, and there has been various arrests in the Western Cape and I think elsewhere in the Eastern Cape, but generally how we deal with them is that when the reports are made or become aware of that, we do institute investigations, and they get arrested and they appear in court, prosecuted and sentenced. So we'll encourage people to continue to report those. In many instances, one of the sources for our reports is these investigations that we do at the HPCSA. So just to respond to the question, when we become aware of it, investigate, and more often it has led us to arrest, and we've arrested quite a number, and they have appeared in courts and were prosecuted and sentenced. So it's in the interest of the public to remove anyone who is not qualified and purporting to be a doctor out there, because we know how that puts our public lives at risk. With regards to the investigations into the private sector, firstly, the companies in the private space that get involved with the corrupt activities or maladministration, they are dealt with. We refer criminal cases against them, against their directors, and we even institute civil litigation to recover monies from them. But in the health services space, through our investigation on the reports that we get from the public, that points to the Council for Medical Aid for medical schemes. We also do, in the presentation you would have seen, there's a whole lot of regulatory reviews that we do. Those regulatory reviews point to some of the irregularities that happened within the CMS, and they would be pointing to various medical schemes. So there's going to be, it's ongoing, but there's still going to be other investigations that are done in the private medical aid schemes. To a large extent, there's also pointers when we do those investigations that leads to some individual medical practitioners, but in the main we look at medical aid schemes in that setup. But where we find that the doctors would have had allegations against them around fraud and all of that, those are dealt with in conjunction with the medical schemes concerned, and the CMS also comes in. Thank you.
Thanks so much, Advocate Mtibi. And with that, guys, that brings to an end our panel. Just thanks again to the panelists, Dr. Graham Howard from the MPS, Advocate Mtibi from the SIU, and Dr. Mark Human from SAMA HRLE and the SAMA board. Thanks so much for the time, guys, and the really robust discussions that were had. And to all the attendees, thanks so much for your time. And do reach out to us if you have any other questions, or if you want to help us advocate for the change we want to see in the health sector. And Advocate Mtibi, we will certainly be reaching out to you for that invitation to join your forum. And let's stand together and build the society we want to see. Thanks so much, everyone, for your time.
Thank you.
Have a lovely day further.
Okay, thank you. Thank you.
Okay, welcome back again. Let me take this time to thank the speakers for taking their time to grace our conference and to share such valuable knowledge. I think I've learned a lot during this morning session. I noticed I did something quite rude in the morning. I didn't introduce myself. For the many that don't know me, my name is Lunga Mfingwana. I'm a pediatric pulmonologist that's based in the Western Cape, pediatric ICU consultant in Tygerberg, that's northeast of Cape Town. And just a note for the general house, because I noted how many questions were coming in during the presentation. I would like to appreciate that after all the talks that we have today, there will be polls that will be going up after the session, at the end of the session. So we would require you to answer those polls, as it is a prerequisite to generate a CPD certificate. And for all the questions that are unfortunately not addressed during these time-limited sessions, they will be referred to the speakers, and these will be posted on our SAMA website during the week. So we're going to move on to the second session, where I'll introduce our next speaker. He goes by the name Dr. Volker Hertzroth. He's a qualified medical doctor at the University of Pretoria in South Africa, and he went on to specialize in psychiatry via the University of Stellenbosch. Amongst other postgraduate qualifications that he has obtained, he completed his master's degree in medical law and ethics, and prior moving to the United Kingdom, where he currently works as a medical legal consultant for MPS. He was in a full-time private practice in South Africa, and he also previously had experience within the public health sector. His clinical interests include addictions, medical law, medical ethics. Alongside a number of colleagues, he founded the South African Addiction Medicine Society. Good morning, Dr. Hertzroth. Over to you.
Hello, and welcome to this talk on managing difficult patient interactions. Thank you for joining me today on this relevant and topical subject. My name is Volker Hertzroth, and I'm one of the doctors working at the Medical Protection Society in the South African team. And it's lovely to be here with you today. Just a brief disclaimer from my side. I mentioned that I'm a medical doctor, so I'm not a lawyer. I'm also going to make reference to 4 cases, and I would like to reassure you that they are true cases, but they have been changed somewhat and anonymized so as to protect everybody concerned. If you happen to recognize yourself in one of those cases, I assure you that it is not you, because we have made some changes so that people cannot be recognized. And lastly, just to remember that during this talk, I cannot give specific medical legal advice today to you, but any member of the Medical Protection Society who wishes to receive specific medical legal advice about a difficult or challenging scenario can email us on that email, which I've put on the slide for you. So, without further ado, let me start with the talk, and this talk is divided into 3 sections, and there you can see them. The first one is just some medical legal facts. Then I want to speak about the causes of difficult interactions and the management of difficult interactions in the third part of the talk. Now, this slide will be shown throughout the talk so that you will be able to follow me and also monitor the progress of today's talk. Working at MPS, I'm obviously quite aware and alive to medical legal problems. And maybe another way of wording today's lecture is not so much about the difficult patient interaction, but also, or maybe rather, who will actually complain about you and who will sue you. So let's have a look at the first case here, ladies and gentlemen. This is a true case that we are dealing with, and the patient wrote a letter of complaint to the HPCSA, and the words and phrases that the patient used in the letter of complaint to the HPCSA included the fact that they believed the doctor had a derogatory attitude and belittled me in front of certain family members. Now, this was in the letter of complaint and indicates that the patient was not happy. Now, of course, we don't know what happened during that consultation, and the doctor may not have had a derogatory attitude, and the doctor may not have belittled the patient in front of their family. But this, be it as it may, was the patient's perception of what happened, and hence the outcome of this clinical consultation was an HPCSA complaint, a threat to institute a summons and sue the doctor for alleged negligence, and then also, interestingly, the patient reported the doctor to the medical aid, requesting a billing audit of the doctor's practice, and threatened to report the doctor to the South African Revenue Service for an audit as well. Another little medical legal tidbit here is that the New England Journal of Medicine some years ago published an article and this interesting table showing the proportion of physicians facing a malpractice claim annually according to their speciality. And you can see that according to the New England Journal of Medicine, the neurosurgical specialty is right at the top, followed by a number of other surgical specialties in the top half of this graph. Interestingly, the non-surgical specialties, the consulting specialties, are mostly in the second lower half of this graph. Now, from our side here at the MPS, we see a slightly different picture in that neurosurgeons are near the top, but also near the top, I would suggest, are our obstetricians in South Africa and the pediatric neonatologists. Now, you can see in this graph, the pediatric specialty is second from the bottom. And my experience would be that pediatrics, and specifically the neonatology part of pediatrics, is nearer the top. And then, of course, in general, the consulting specialties are nearer the bottom. The next slide shows another graph from the same article and indicates the cumulative career probability of facing a malpractice claim or indemnity payment according to the risk of specialty and the age of the physician. And in summary, you can see that the left-hand vertical axis shows the probability of the first claim against the practitioner, or then the indemnity payout, whilst the horizontal axis shows the practitioner's age. And maybe just to give you the brief overview, the top curved line is maybe the most interesting, which seems to suggest that the practitioners in the high-risk specialties, so maybe here see the surgical specialties and pediatrics and neonatology specifically, would usually receive a claim in alleged negligence quite early on in their career. The first claim, or for that matter, a later payout of indemnity money, would be quite early on in their career compared to the lower risk specialties. So let's have a look at some more medico-legal facts here. A number of studies have shown that of all hospital admissions, 10% involve an adverse outcome. Half of these adverse outcomes seem to be preventable, and only 5% of patients who suffered an adverse outcome took medico-legal action. Now that's an interesting statistic. Furthermore, studies have found that many medico-legal claims do not involve error, or a medical error, a medical mistake, or for that matter, negligence, clinical negligence. So many medico-legal claims and actions and consequences do not involve a medico-legal error, a clinical error, or clinical negligence. There was no error found in 37% of medico-legal actions. Now that's an incredible number. That means more than a third of medico-legal actions actually had no clinical error on the part of the practitioner. Interestingly, again, no injuries were found in 3% of actions, and that's a bit odd because you would assume that if a patient institutes a claim in medico-legal negligence, there must be some sort of harm or injury. But it could be that this 3% of actions is instituted because of other reasons other than harm or injury. Our own data here at the Medical Protection Society seems to suggest that many, indeed more than 50% of our claims are successfully defended or have been withdrawn by the plaintiff, which would suggest again that more than 50% of claims seem to be unfounded. And you can see here that from 2015 all the way through to 2020, more than 50% of the claims that we've had to deal with have been successfully defended or gone away, except for 1 year, which was 2017, which seems to have been a slightly bad year for us. So, ladies and gentlemen, you're going to be wondering what this is all about. And where I am heading with this to get to a difficult patient interaction is the following few slides. It seems as if the medico-legal risk does not necessarily correlate with your clinical competence. There are other things that seem to be driving medico-legal risk as well. And here we have some of them. There are a number of factors in the decision to take medico-legal action against you. So what this means is patients weigh up numerous other factors before or in order to decide whether they take medico-legal action against you. And here they are listed. There are usually a number of predisposing factors that have occurred or that the patient has perceived to have occurred. And one of those is rudeness, alleged rudeness on behalf of the practitioner, or delays, inattention, a practitioner who shows no empathy or who is arrogant, who is apathetic, and who does not communicate or miscommunicates. These are a number of predisposing factors that lead into a patient deciding to take medico-legal action against you, such as a complaint at the HPCSA. And you can see where this is going to link up with a difficult patient interaction. The second group of factors are the precipitating factors, and that is maybe an adverse outcome, an injury, an iatrogenic injury, incorrect care, or other system errors or mistakes. So what this slide would suggest is that there often are a number of predisposing factors that might just make the patient decide to take further action against you, whilst if those predisposing factors were not present, possibly the patient might not necessarily take the medico-legal action against you. So what am I saying, ladies and gentlemen? I'm suggesting that poor communication and low patient satisfaction are linked to patient complaints and medico-legal action against you. If we put this another way, then patients seem to be reluctant to sue or complain about doctors that they actually like. Now that's an interesting thought. So, it is important for all of us to realize that patients assess our clinical competence based on our interpersonal skills and our interactions with them during the clinical consultation. Patients tend to trust doctors who they see as being caring and competent. And that in a way makes sense, because patients would struggle to judge our clinical competence, but they are very good at judging our interpersonal skills and our interactions with them. So here's another case, another true case. In the letter of complaint to the HPCSA, the patient wrote the following, referring to the doctor. He was running very late and then said, "I cannot be rushed and you can just rebook." The patient also said the doctor was incredibly unprofessional, very rude, unkind, and insensitive. And lastly, the patient said that the doctor was disrespectful of my time and my work. And here it's probably worth remembering that patients also give up of their time and their employment time and their income possibly to come and see us in our practice. And of course, if there are some of those predisposing factors, then patients can be angry and dissatisfied. And in this case, this patient sent a complaint to the HPCSA and made a threat to place a post on social media. So, much of what I've said does relate to a difficult patient interaction. And all of us, independent of whether we are general practitioners or various specialists, occasionally have to face a difficult interaction and have to manage it successfully so that we do not have an adverse medico-legal outcome, and of course, not an adverse clinical outcome. So, let's have a look at some of the causes of difficult patient interactions. And the academic literature has numerous good articles on this. And if I was to summarize findings in general, I would say that there are 4 separate factors that determine whether an interaction with a patient can be or is going to be difficult. And here I've listed them for you. There are a number of patient-related factors, there are disease-related factors, there are system-related factors, and of course there are doctor-related factors that are all about you, your style, your knowledge, and your bedside manner and clinical interaction with the patient on the day of the consultation, or maybe in follow-up arrangements with phone calls. So a difficult interaction tends to be caused by a number of factors or processes. Let's look at these in detail, and you will recall or remember much of what I've said from difficult patient interactions that you might have had. Have a think back of some of your patient interactions that you would define as being difficult, and let's place some of these factors that cause the difficulty into that clinical context of yours. If we look at patient factors, there are three that I could distill from the literature. And the first one is patients and their supposedly unrealistic expectations. The second patient factor is what we would call a discordance between the disease and the illness, and I will elaborate on that on one of my next slides. And finally, if there is rigidity on the patient or your behalf regarding the various alternatives and options available to a patient. So let's interrogate these in a bit more detail. Unrealistic expectations. Well, we've all faced them in our clinical scenarios, in our clinical consultations. You would have had many of these, and I had them when I was a clinician practicing. Patients have preferences and expectations about all aspects of healthcare. Of course they do. They Google, they hear it from friends, they hear it from their best mates, and of course they hear it from everybody else in the media. And that has maybe been especially so in the last 18 to 24 months. Unmet expectations often lead to patient disappointment. And when patients are disappointed, it is easy to blame the other, or for that matter, to blame you, rather than share the disappointment. So the management of unrealistic patient expectations is very important to reduce the chance of a clinical consultation ending up being difficult. So how do we do that? And here are some hints. Identify patient expectations early on, during the first half of the clinical consultation. Listen to the patient for a good long time and hear what they have to say. And then ask them, what would they like to have achieved during this consultation? What are they expecting you to do? Flush out their expectations early on so that you know where you stand and what your options are. And if there are unrealistic patient expectations, then address these calmly, patiently, and professionally. Don't ride roughshod over them, don't negate them, but deal with them professionally as any good doctor would. Remembering that unmet patient expectations can lead to disappointment, complaints, and medico-legal actions, as my two previous cases have demonstrated. Another patient factor is the discordance between disease and illness. And here it's worth pointing out maybe that discordance makes us uncomfortable. And discordance often occurs when there are different interpretations of various facts. Disease is what you and I have studied for many years and what you and I see in our clinical consultations. It's all about pathology, physiology, it's about signs and symptoms, it's about treatment options, and so forth. Pharmacology, surgery. That's the talk that you and I do. That's what we're good at, and that's what we've studied so long for. That's what we're the experts on. But illness is the patient's experience of that disease. And every patient experiences their disease differently. They have different thoughts, they have different feelings, they have different fears, and of course they have different expectations. And if there is a big discordance between the disease, that's us on the medical side, and the illness, which is the patient side, then there are possibilities that this could become a difficult patient interaction. Similarly, if there is what I call a band of comfort that seems to be quite rigid, then there is a chance that the consultation will deteriorate into increasing difficulties. If there is rigidity regarding the various alternatives, the options, the treatment choices, then you may not find common ground with your patient, and there remains this gap, this space where you two are not meeting. You and the patient are not meeting each other in the center ground, and that can cause difficulty for you, for the patient, and of course ultimately adverse medico-legal outcomes. The second large group of factors that contribute to a difficult patient interaction are disease-related. And here I've just listed some of them, and you might even recall from your studies some of the disease factors. We know that patients who have multiple various complaints at the same time occasionally are difficult to manage. Patients presenting with chronic pain, or those presenting with alcohol and drug addiction, often also are difficult situations to manage. And finally, mental illness, and especially the personality disorders, are occasionally patients who are difficult to manage. And the literature seems quite clear that personality disorders seem to feature quite prominently in the studies relating to difficult patient interactions. And I'm sure you have a few other conditions, diseases that you feel contribute to difficult patient interactions. The third group of factors or causes that contribute to difficult patient interactions are system factors. Those are beyond you and your patient, and they relate to the system that we work in, that we live in, and the society that we function in. And here we have time pressures, how your diary looks, what your personal life looks like, and how you interact with time between your work and your private life, how full your secretary books your practice, whether or not you allow or permit interruptions by phone calls, consultations, or for that matter, staff members, whether or not your consultations are private, or whether there's noise in the background. Cultural differences, of course, are equally important. Limited resources, we've seen much of that in the last 24 months, not just in South Africa, but across the world. When you do not have the resources that you want or that you need, knowing what you want and need to provide good patient care, then things get difficult. People get impatient, expectations are not met, and you might end up with a difficult patient interaction. And of course, there could be endless third-party pressures from family members, from insurance companies, from the medical aids, very prominent in South Africa, who seem to pressurize practitioners and, for that matter, also patients down certain treatment alleys. All of these system factors cause and contribute to potentially difficult patient interactions. And finally, the last group of factors relate to you and me, to us, to the doctors, to ourselves. And that is our own personality. We all have our own little quirks and foibles. We all have personality traits, although I would hope that we are not particularly personality disordered. But be that as it may, our own style of thinking, acting, and interacting contributes to patient interactions and occasionally might contribute to a difficult patient interaction. If you've had a previous encounter with similar people, maybe you've seen numerous drug and alcohol related patients, or for that matter, patients with chronic pain, and you've had previously negative encounters. Maybe those patients, or one or two of them in any event, complained about you at the HPCSA, and now you find you are unsure, anxious, and worried about dealing with patients with chronic pain or drug and alcohol related problems. The degree of training and how much you have skills to handle difficult situations. What were you taught in your undergraduate training about how to deal with difficult situations and difficult people? Maybe in your specialist training, you received some training about how to manage such scenarios. Now, sadly, I suspect none of us had enough of such training, but I recall from my undergraduate training that I did have a lecture or two on how to deal with difficult people and difficult scenarios. We all carry our own emotional baggage. We all have our own psychological twists, and hence that could contribute to a difficult patient interaction. We all have certain views. We all have our own mental health concerns. And lastly, what we call the susceptibility to HALT stress. Now, you might be asking, what does HALT stand for? And of course, that stands for hungry, angry, late, and tired. And again, the South African healthcare profession has a lot of that, where our practitioners are tired, they are overburdened, overworked, and exhausted. And all of that will reflect in your patient interactions, your consultations, and potentially lead or contribute to a difficult patient interaction. So, how can such difficult encounters make us feel? How do you feel? What do you feel like after or before you've had a difficult patient interaction? Maybe you can see a particular patient in your diary later in the day. How do you feel about it when you know that that might be a difficult patient interaction? And what do you feel like after you've seen such a patient? And here's a list. In general, the literature suggests that healthcare practitioners feel frustrated, resentful, fearful, or even deprofessionalized with system factors. Angry helplessness, hopelessness, and powerlessness when you are working in a bigger system where you have very little say and you know that your clinical autonomy is frustrated on every move and every turn. And then a patient is in your consultation who has an unrealistic expectation and you're still running late, not having had lunch. All of that leads to a difficult patient interaction and makes us feel frustrated, resentful, and possibly angry, hopeless, and powerless. So that perception of difficulty, that feeling, that emotion that you and I feel in those instances also affects our further behavior. So things could become a vicious cycle, a circle and a merry-go-round where things just reinforce difficulty and challenges. So how do you greet such patients? Our perception of difficulty affects the way we greet these patients. Our non-verbal body language also expresses how we feel, and we need to be aware of that. When you see such a patient, when you see them in the waiting room, when they walk into your office, what is your demeanor like? What is your facial expression like? What is your body language like? Such perceptions also pollinate the degree to which we listen to our patients. Do we switch off early knowing that this will be difficult and you cannot resolve the problem? You cannot address the multiple complaints and you cannot relieve the pain. Do you stop listening to your patient at that point? Do you just wish that the time would tick over so that you could move on and go home? All of that is sensed by our patients. The information we provide, of course, is also determined by our own views, thoughts, fears, and perceptions of such scenarios. And whether or not you involve the patient ultimately in the joint decision-making, as you should, will also be determined by how you feel about these encounters. And of course, all of that will potentially lead to a difficult interaction and a possible complaint or medico-legal challenge later on. So here's another case, ladies and gentlemen. It's a true case. And the patient, in their letter of complaint, wrote that the doctor, she was very rude to my mum. She carried out the assessment in a very arrogant manner, as if she was doing me a favor. She came in late, coughing and blowing her nose. Now, during the time of COVID, that would have been a worry for the patient. The doctor did not seem interested in my symptoms, and she obviously thought that my illness was not serious. And this patient sent a complaint to the HPCSA about this practitioner's conduct. And unfortunately, the practitioner is now embroiled in a lengthy, complicated, and uncertain HPCSA complaint. And you will notice that none of this has to do with the clinical acumen of the practitioner. It all has to do with bedside manner and patient interaction. So, ladies and gentlemen, what can you do about such potentially difficult patient interactions? And I've looked at the literature, and I'm going to show you two articles that I've come across. They're available on the internet. I can't vouch that they are truly brilliant articles or not, but I thought they each provide a good overview and an easy to digest narrative that would help the average practicing healthcare practitioner in South Africa. So the first article is this one. It's a very recent article you will see in July 2021, published in Current Psychiatry. It's about managing difficult patient encounters, and it's written by Professor Black, who happens to be a psychiatrist. There's much of this sort of literature in the mental health and psychiatry literature. And Professor Black highlights the three types of contributing factors: the patient, the doctor, and the system. Now, that is similar to what I've mentioned earlier. I've also added in the disease or the illness for that matter. But this is a very good overview article that all of you can access from the internet, and it makes interesting reading. The second article that I came across is somewhat older, but it is this one in the American Journal of Medicine from March 2015. And it is about what mediators can teach physicians about managing difficult patients. And when I read this, it's only about 3 or so pages, so it's not a particularly long article, and it's easy to read. It highlights 7 skills that mediators use during difficult mediation processes that they believe doctors could also use when they manage difficult patient interaction. So an easy to read and easy to understand article with some useful and helpful hints that I think would help every practitioner when they deal with a difficult patient interaction. Other than those 2 articles, I thought I would just share some practical advice. Much academic research on the practicalities of difficult patient interactions is out there, but here's a brief list of some practical advice, and you will hopefully recall some of this from your training. But it is thought that regular short visits on a predictable, usual, standard day and time would help such patients, rather than having many unscheduled and urgent visits at short notice that are pushed into a very busy day already. So routine and repetition and regular contact with such patients will probably ease your burden and assist the patient. It's also worth remembering that you might want to consult such patients at the end of your busy day, in case there is some overrun, so that you're not pushed for more time and other patients are now impacted and run late too. So plan it for the end of your day, so that you have enough time to manage whatever the patient brings to your consultation room. Remember, you're not alone, although it might feel that way, but there are many doctors who will have a lot of sympathy with you in your situation, because every one of us has had to manage and help difficult patient interactions. So request an occasional second opinion, and I'm sure many of your colleagues, either in the practice or down the road, would hopefully be happy to give you a quick second opinion. Consider specialist referrals as needed, but of course you don't want to over or under refer to specialists. So it is a bit of a difficult decision-making process, but sometimes specialist referrals do help, just to either confirm that you're doing everything right and you've not missed anything, or to point out a further option and avenue that you could explore. Remember to do regular and detailed physical examinations and document those in your notes. They are reassuring to the patient and they help you ensure that you're not missing anything. Do targeted special investigations. Of course, again, you don't want to over or under investigate, so you need to choose your special investigations cautiously and with clinical appropriate core motivations. Get collateral information, very helpful to speak to a family member, to speak to the patient's spouse, with patient permission, of course. Might confirm much of the information you have already, and hence your level of worry and anxiety and uncertainty can be reduced, and you might feel reassured. Of course, collateral information might also provide you, again, with further helpful new information that you might have missed. Ensure that you have peer support, because managing difficult patient interactions can be challenging and very draining. So speak to your peer in confidence. Share your burden with a colleague in confidence. Ask advice, or just time to share your concerns. The ultimate big worry, of course, in such patient presentations is that there is a real risk of missing a serious condition, because you're so used to this patient having multiple complaints that are unfounded. You might miss a serious condition. And here I just want to point out that we should all beware of the known imitators, the known high-risk conditions, various cancers, paraneoplastic syndromes, autoimmune diseases, various infections, tuberculosis, syphilis. All these conditions can present in multiple, complicated and complex ways, and you wouldn't want to miss any of those. So have a high index of suspicion for true and genuine illness, but manage the patient appropriately. And of course, the literature is full of much more helpful and practical advice. And if you happen to have a handful of such difficult patient interactions, it might be worthwhile to recap some of the literature or your undergraduate notes. So, ladies and gentlemen, practically, what can you do? This is an important slide, and I would like you to focus on it and just imbibe this slide and the 5 bullet points that I've listed here. The best thing you can do with difficult patient interactions, so as to help the patient, help yourself, and prevent a medico-legal complication later on, is this list of 5. Connect with your patient. So it's about that doctor-patient relationship. Listen to them. Give them a minute at the beginning of the consultation just to share their concerns and fears without interrupting. Empathize with their experience, and then gently ask for more information. Ask them to elaborate. Ask them to expand on their fears and their experiences and their expectations. And then towards the end of your consultation, review everything and check that you've got it right. Ask them to confirm. Ask them to check that what you're saying and thinking is correct. Can they confirm that their concerns are whatever they might be? And can they also confirm that they are happy to proceed with the following treatment plan? And then listen to what they say. Ask open questions and give them an opportunity to respond. So overall, ladies and gentlemen, you can choose how to respond to difficult patients and difficult patient interactions. You can choose which way you want to manage such consultations. And that, of course, immediately brings the next question, ladies and gentlemen, which is, so what is an effective response when you are dealing with a difficult patient interaction? And here we go, ladies and gentlemen, a conscious, skillful action in the best interests of the patient would be the best response. And this is now an important part here. It may require you to diagnose and manage the actual interactional difficulty before you get to the clinical diagnosis and the management of the disease. So you might have to diagnose and manage the difficult interaction before you actually get to manage and treat the disease. Now that might be somewhat challenging, but let's have a look. A number of effective skills and strategies are available to us. And maybe the first one here is you need to recognize in your own mind that there is an interactional difficulty. Now that might seem obvious, but some practitioners seem to struggle with this too, seeing the number of complaints we have about this. So in your mind, recognize during the consultation that this could potentially be an interactional difficulty. This could possibly now turn into a difficult patient interaction. And then you might choose to diagnose that interactional difficulty more formally, and we will give you some example on some of the next slides. Throughout this process, please continue to support the patient. Remember, this is not confrontational. It is about supporting the patient and guiding them into good clinical care. Acknowledge the problem to the patient, and occasionally, if needed, and if there are unrealistic expectations, state your boundaries clearly, but calmly and professionally. So how do you recognize this interactional difficulty? And sometimes it's easy and sometimes it's not. But take note of the verbal and non-verbal mismatch from the patient. What are they saying and how are they acting? Or how are they acting and what are they then subsequently saying? Is the patient interrupting you? Are they repeating something that they believe you have not heard? Or are they just shutting down and being quiet because they disagree with everything you've said? Are you aware of these sort of cues during your consultation? And you should be. Unexpected patient resistance or opposition to what you said might be a signal that there is an interactional difficulty. Or when you find yourself disengaging from the patient, when in your mind and in your thoughts you've already moved on and you're having some maybe particularly negative thoughts about the patient and the interaction. Stop yourself, recognize where you are, and then recognize your own negative thoughts and emotions as I've mentioned. And then comes the diagnosis, the process of diagnosing the interactional difficulty. Think to yourself, what is the difficulty? Where does it lie? What does the patient think about all this? Are you actually on the same page with the patient here? And then how can I approach and deal with this interactional difficulty? Throughout this process, I mentioned, continue to support the patient by active listening. Demonstrate an interest in the patient's reality in whichever space they're in, and whatever they fear and worry and expect. Demonstrate an interest. It doesn't mean you have to agree, just demonstrate an interest by active listening. And occasionally clarify the difficulty by asking some respectful questions to demonstrate a deeper understanding of the patient. Again, it doesn't mean you have to agree with the patient. You are just trying to clarify what they are thinking and what they are wanting and what they're expecting. Just merely asking gentle, probing, open questions will deepen the patient's thoughts, feelings towards you. They might even start liking you and hopefully not complain about you. Show empathy. The patient must be heard and understood, no matter what space they're in, no matter what thoughts they're having, and no matter how much they disagree with you. And then, like I said, review, summarize, and reflect back. Check whether you have understood correctly. And then integrate everything into the patient's agenda, your own thoughts, your own plans, and your own treatment approach. Try and integrate that into the patient's agenda. Might be difficult occasionally, but the more you do it, the easier it will become. And then you could acknowledge the problem to the patient. And I'm going to show you some examples just now. So you might want to verbalize your diagnosis of the difficulty, of the interactional difficulty, to the patient. You might even seek their agreement. They might also feel something like an interactional difficulty. They might agree with you. You might even be on the same page when it comes to the diagnosis of this difficulty. And then by agreeing on the nature of the difficulty, you may be able to facilitate the solution and move forward and progress the patient's care. So on the next slide, I've got some examples for you. There we go. Some examples of how you could approach this process. You could say the patient's name. So in this case, let's use John. John, you seem to be asking me for guarantees, and I cannot give you any. That's making things quite difficult between us, isn't it? You can see there's no confrontation there. There's just a kind, courteous, professional discussion. Or Mrs. Sethi, it seems to me that while I'm very concerned about your condition, you believe that it is not serious. That's causing us some frustration. Is that right? Can you see how the interactional difficulty has been mentioned and highlighted and pointed out in a very kind and caring manner? There's no confrontation. There's no disagreement. There's just a sharing of concerns. Sometimes patients have unrealistic expectations, as I mentioned, and then you can state the boundaries, because breaching such boundaries can lead to feeling trapped for the doctor, cynicism, shaken self-respect, anger, and medico-legal consequences, and that's what we see. Doctors are often asked to do certain things, to prescribe certain medications, or to follow a certain treatment approach that the doctor might disagree with, but the patients are insistent, so they are pushing your boundaries. And from our side, we often see that such problems, when they occur, result in unethical, illegal, or immoral conduct, or at the HPCSA, unprofessional conduct. So clearly state your boundaries calmly, factually, and respectfully, not confrontationally and in anger. Be flexible with different patients in their different clinical contexts, of course. Tailor-make your approach to each patient and their problem. And always explain your reason for upholding the boundary in terms of the patient's best interest. Now that might sound contradictory, but I'm going to show you examples on the next slide. How you could tailor your explanation and your reason for maintaining your clinical boundaries in terms of the patient's best interest. So let's have a look at two more examples here. Another two examples. Mrs. Jindal, I want to make sure that we get the best possible result for you and that nothing we do jeopardizes your future prospects. Can you see how this is termed in terms of the patient's best interest, the best possible result for you, and that nothing we do jeopardizes your future prospects or your future health? Second example, something like, because of that, I won't be able to go along with your request for me to provide you with that medication. So in order to provide you with the best possible care, I won't be able to go along with your request for me to provide you with that extra medication, or that higher dose, or that longer prescription, or giving you a prescription without seeing you in my consultation room and checking that you are still healthy and all is well. So again, there's no anger, there's no confrontation. They are just kind words and a suggestion that you would like to provide the best possible care to the patient. So, be solution focused. Focus on good clinical care, and then slowly move your consultation towards a mutually agreed way forward, which is often more effective than debating points of disagreement and getting into an argument and digging your position in, while the patient will then subsequently dig in their position. Assist the patient to identify and generate various solutions, and that would encourage ownership and implementation. Ultimately, it would encourage compliance with the agreed treatment plan. Patients may require significant encouragement and support to generate solutions, because we've all had patients sitting in front of us who just cannot generate any options. And then it all falls back down to you. The clinician, that is you, while you are free to offer suggestions, you should avoid taking over the process of problem solving. It's not for you to necessarily come up with all the options and solutions. It is just for you to come up with the clinically relevant and good solutions and place those on the table. And if need be, gently and kindly repeat them and explain that they would be the best solutions or the best options or the best treatment in your view, as you would only want the best care for your patient. And I've mentioned already, try to avoid arguments. Stay solution focused. Keep that patient relationship going, and try not to prove that you are right and they are wrong. Avoid the but and the why and the with respect comments. Try and engage the patient and draw them into your treatment plan by pointing out what we've mentioned earlier. And when you ask your review questions, your summarizing questions, do so in a manner that the patient can agree with, so that you both come forth at the end of the consultation having agreed on a treatment plan that both of you feel is in the patient's best interest. And finally, respond to the emotional content rather than any irrelevant, incorrect, or exaggerated words. Patients, and unfortunately doctors too, occasionally say things that might be inappropriate, that might come out in anger. Try not to do that. Try to leave out the arguments, the anger, and the irrelevant, incorrect, or exaggerated words, and rather deal with the problem at hand. And I'm coming to the end of my particular talk today, and I want to finish with another case. The last slide for today is another true case. And here the patient wrote in the letter of complaint to the HPCSA. The doctor became condescending, judgmental, and hardly paid any attention to what we were saying. The doctor accused me of a certain thing. They used a confrontational tone, and he banged his fist on the table. He aggressively stated that he wanted a yes or no answer. He cut us off, shouted, and was so irate. Now again, we don't know what happened in the consultation, but this is what the patient experienced at the time. Now, I would hope that this is exaggerated, but we don't know. As I said, we were not there. But be that as it may, this is the complaint that was lodged at the HPCSA. And again, I would like to point out, it's not about your clinical acumen. This is not having made a diagnosis incorrectly or a wrong treatment plan or some side effect that they weren't informed about. This is about bedside manner. This is about your interaction during the clinical consultation. And unfortunately, this resulted in 2 complaints, an HPCSA complaint and a complaint at the hospital. So, ladies and gentlemen, having now come to the end of my talk, I will open the floor to questions, and I will certainly be available for that. I thank you for your time, and thank you for spending the last 45 to 50 minutes with me here today. Thank you and goodbye.
Questions that have been popping up on the chat, but just to ease onto the questions, I have a few of my own. This is a very interesting talk, and maybe if I can answer questions, I'm going to give you a scenario. I think it's something that we see as pediatricians. I actually thought that we were at the bottom of the list from your graph there on the doctors or practitioners that are facing complaints and being sued. It's interesting that we've moved up the ladder. But I think one thing that we are faced with, and especially being a young consultant, is in our tradition or in our culture, being in South Africa specifically, you find that the grandmothers feel they're entitled to be the first part of communication before you speak to these young mothers. And as such, when you have to address such issues to say, no, we need the mom to be around before we discuss any information about the child, or first to get a consent from the mom to actually discuss such information with the relatives, it's actually not taken very well by the family. And as such, when there's an adverse incident that happens while the patient is being admitted or during our encounter, then you find that the grandparents actually influence the steps of the family that is going ahead and lodging a complaint against you. So I guess just to summarize the question is, how should a doctor respond to managing adverse events?
Thank you. And an interesting question, and one that we occasionally have to respond to. Of course, the South African clinical context relates to various cultures, various ethnicities, various languages, and that is the joy of living in South Africa and working with South Africans. But of course, it adds to our challenges and to our problems, because our current medico-legal framework and the medico-legal structure, the HPCSA and the National Health Act and the Children's Act, are all very much based on autonomy, patient autonomy. So the patient reigns supreme. They get to choose. As long as they have the mental capacity to make decisions, they can choose what treatment they would like. And that, of course, is very much maybe in contrast to more traditional societies or more traditional philosophies. And the academics will have a field day on this to try and bring the two together, the autonomy-based side of things with the cultural, family, social-based traditional view. Be that as it may, and we are where we are. And in that sense, of course, like I said, the patient has autonomy and can choose who to involve in their care, who to disclose information to, and who to listen to. Now, you ask about how to respond to an adverse event, and that is a question that we often get emailed and asked. Doctors are fearful because they've just had an adverse event, maybe yesterday or even this morning, and they don't know what to do. They don't know who to speak, and for that matter, maybe most importantly, they don't know what to say. Now, there is no textbook answer to this, ladies and gentlemen. This is something that you'll have to manage, and it's one of those skills you'll have to learn. But some of the basic principles might be something like, firstly, don't run away. The doctor-patient relationship continues. There's been an adverse event or an adverse outcome, and you cannot run away. The second, maybe equally important step would be, contrary to what many people think, we do advocate that you are generally open and honest with the patient and their family if appropriate. Don't hide away, don't obfuscate. Be generally professional, open, kind, caring, and truthful. You've got to explain the facts as they are, as they happened. Probably best not to speculate if you don't know. So if you don't know what happened, then you say that. Then you say, I don't know what happened here, but we can find out. I'm going to investigate. So I think that's important. Open, honest. Don't hide, don't run away. Be available to your patient, because remember now, your patient might be in even more distress than they were at the beginning. They're probably very anxious. They don't know what happened. They're in a strange place, maybe an ICU. So be available to them. Be around. Tell them that you'll come back later in the day. You will check on them. So reassure them of your availability to provide ongoing care and help them through the challenges they face. Now, occasionally, it might be difficult for you, or for that matter, occasionally the patient might not want you to be their treating doctor, and that's okay. Handle it with a professional attitude, ask if they are happy for you to continue, and for that matter, if need be, offer to refer them to a colleague, a second opinion. So maybe that's just some broad-based bullets there for you, Dr. Lunga.
Okay, thank you very much. I think you partially answered my following question. That is, what can doctors do to reduce medical legal risk? Do you want to comment on that further?
I gladly will. Now, my whole talk was basically premised on the idea, or for that matter, what we now think is pretty accurate, the idea that patients cannot judge your clinical acumen. They haven't studied the pathology textbooks. They haven't studied the South African medicines formulary. They base their judgment of you on your interactive style. So how can you reduce your risk? Well, I said earlier that it tends to be patients don't sue doctors they like. And interestingly, earlier last week, there was a claim in negligence where it turns out the patient actually instructed their attorney not to sue a particular doctor in the whole chain of clinical contact, because they liked that doctor, and that doctor actually spoke to them repeatedly after the problem. So that's as far as it goes. So it's very powerful having a good doctor-patient relationship. What can you do to reduce your medical legal risk? Well, work on your bedside manner, interact with your patients in a kindly and professional manner. But then maybe one other important or two other important things, and I haven't spoken about this in my talk, is get full informed consent. Patients like knowing what is going on. Patients like knowing what is wrong with them, and they like to have a few options that they can choose from. And they want to know that you're okay with some of those options and maybe not so with others. So good, full, informed consent in a professional, normal, wonderful discussion with your patient. Please write that conversation down. And then maybe a last point on this one is manage your patient's expectations. When a patient walks into your consultation room in a wheelchair, or rolls in a wheelchair, and expects to walk out of theatre, well, that's an expectation they have, and you're going to have to manage that. Same if a patient has severe pain and wants to walk out of your consultation room without the pain. That is an expectation they have, and you have to manage that. You have to address that. And maybe you have to just tone it down and tell the patient that it's unlikely that you will be able to fully cure them. But let's try something. Let's see where it goes, and then I will follow up and we will make next decisions. And maybe a quick final one that has just come into my head is respond to your patient queries. When a patient asks a question, or for that matter, phones your secretaries or phones the departmental secretary, please respond to that call. Don't ignore it. Be available. Even if the secretary just phones back and says the doctor is in theatre, he will get back to you after he's done with the theatre session. So please respond to patients. Don't ignore them.
Okay, that's a very comprehensive answer. Just the last one before I go to the other questions that I have on the chat. So, what can one do? We're living in a very interesting world where I think some countries are in 7 IR and we are already on the 5th IR, where it's videos and videos and social media. And you find patients that want to record a consultation. How can one go about addressing this?
That's a good question, because we see this. Ladies and gentlemen, let's start off right at the beginning, which is it could very well be that patients are recording you during your consultations. Some of them might even ask you whether they can record a consultation, but somewhere I believe that in the back of my head that more doctors are being recorded than actually know about it. Now that seems to worry doctors, maybe even understandably. You're concerned about being recorded and you don't know what's going to happen to that recording. You don't know whether it's going to be placed on Facebook. You don't know whether it's going to be sent to 1,001 contacts. So, of course, doctors might be concerned. Of course, also, remember, or maybe you won't know this, but we've looked at this question. And having looked at the law about recording consultations, it turns out that the law is rather complex because there are various legal acts that have there, the Electronic Communications Act, and so on and so on. So there's a whole bunch of them. And the short answer, maybe just practically for you and me here today, is the law is complex, but it tends to favor the patient. So you probably cannot sue a patient or complain about a patient recording you, even without your consent. My best advice to you would be treat every patient as if they were recording it. So be professional in all your interactions, because you might be recorded. Interestingly, maybe for the audience, we have cases where recordings came out after the event, much later, 2-3 years later, and there suddenly came out a recording of maybe a consultation or a quick passage conversation with a family member, or for that matter, even a CCTV recording from the hospital. And they made a big difference, sometimes to the good, of course, and sometimes to the bad. So recordings are becoming increasingly important. If you are asked whether you should permit or whether you would agree to recording, well, then I suggest you answer in the affirmative unless you have a very clear reason not to. Maybe that's a quick, shorter answer.
Okay, thank you very much. Again, I would like to appeal to the audience that we might not go through all the questions in the chat. So if we fail to address all the questions, they will be posted on the SAMA website. Just a question on the chat speaks to, do physicians have a legal recourse when they've been wrongfully accused, and as such, they've been defamed and they've lost income during the process?
Yes. That's a hard one for doctors. Because, well, let me tell you a story. I recently came to an end of a criminal trial for a doctor, and this turned out to be a 3-year affair with much media exposure, and it all came to an end, and the doctor was acquitted of the charges. It was a long, hard slog for everybody, and I phoned the doctor, and as I phoned him, the doctor was actually driving home after the court appearance. And that was all there is to it, ladies and gentlemen. It was just the end. After 3 long, hard years of stressful life, of ruined career, of loss of income, it was a matter of, thank you, the court's done, you're acquitted, you can go home. So the short answer maybe to the question is, do doctors have a recourse? In general, no. Anybody can complain about your conduct, even if their complaint is irrelevant or wrong. The justice system affords everybody an opportunity to complain or to sue, and there's very little you can do about it before or after the event. Now, very rarely, there is what we call a vexatious litigant. Now, that might be somebody who keeps on repeatedly suing or complaining about a doctor or a group of doctors. And we see that at MPS. We have such litigants or claimants or complainants who keep doing the same and keep re-complaining about a group of doctors or an individual. And of course, there we take action and we engage with the appropriate stakeholders. We have also, in a few cases, actually taken the legal route to stop such vexatious litigants. But just because somebody complained about you and their complaint was allegedly then later found to be unfounded or unreasonable doesn't mean you've got recourse. And that's the hard truth, and it's very sad and hard for doctors.
It's very sad indeed. That's very sad indeed. So just one last question before I let you go, Doc. Very interesting question. If one has persistent interactional difficulty with a patient, how does one decline to see that patient again?
That's a good question as well, because we occasionally have these coming through to us here at the Medical Protection Society. In essence, maybe the question is, are you obliged to keep seeing difficult patients? Or maybe worded another way, can you end a doctor-patient relationship? And I will try and keep it short. The short answer is, in an emergency, you may not decline to see a patient. So if there is something urgent or emergent or an emergency, I would urge you not to decline the patient. See the patient, consult with them, deal with the challenges, and try and treat the emergency. So in an emergency, you cannot decline. There are, however, in routine care, methods of you terminating the doctor-patient relationship. That's an unfortunate word, but you can end the doctor-patient relationship. Please be cautious about doing it. You cannot just phone the patient and say they're not welcome. There is a process of doing that you would be urged to follow. If you need advice about that, then please let us know at the NPS and we'll provide you with some stepwise guidance on how you should approach ending a doctor-patient relationship. Thank you.
Okay, thank you very much. We'll move on to the next speaker. I'll introduce to you Professor Rajan Naidu, who will speak to us about protecting the front line, that is occupational exposures and occupational disease in clinical practice. He's a full professor and head of department in the occupational and environmental health at UKZN, and has been in the academic research sphere for over 25 years. His areas of research focus are on occupational and environmental respiratory disease, with projects funded by major national and international agencies, including the National Research Foundation, the US National Institute of Health, and the European Union. He has over 95 peer-reviewed publications with presentations at several international conferences. He is one of the advisory board in the International Archives of Occupational and Environmental Health and the American Journal of Industrial Medicine. He received his postgraduate training in occupational medicine at the University of Cape Town and his doctorate at the University of Michigan. He serves on the National Department of Health, as well as an occupational health and COVID-19 advisor on NEDLEC and the MAC Workstream 4 on vaccine rollout. He has been involved in the drafting of the various National Department of Health guidelines for workplaces, as well as the Department of Employment and Labor Direction on COVID-19. Professor, we welcome you and please do take the stand.
Good afternoon, colleagues and friends. I'd like to say a very big thank you to the organizers of this conference for giving me an opportunity to talk to you about some of the problems faced by our doctors in their clinical practice. My title that you see on the screen now will vary slightly from what you've got on your program, but I decided in discussion with the organizers to move away from focusing just purely on safety, but to look at some of the issues related to the occupational exposures and how these give rise to occupational diseases in clinical practice. So on the basis of this, the title of my talk is essentially how do we protect doctors against the adverse health outcomes that they experience as a result of their occupational exposures in their clinical practice. But before we start talking about doctors specifically, let's take a step back. In the world prior to the SARS-CoV-2 virus, we know that already over 2 million workers die every year from an occupational disease, 300,000 from an occupational injury. So even though we as doctors feel as if we're immune to the problems of workplace exposures, we may be part of this very, very concerning statistic. It costs $3 trillion to the global economy because of occupational diseases and injuries. But yet, if you think about the amount of resources we spend addressing this problem, it becomes quite concerning. So the International Labour Organization provides this and emphasizes this statistic and basically demands of us to look at how we address the problem. But we as doctors, while we're on the front line trying to protect the health of others, we also need to concern ourselves with how we protect our own health. This came into very sharp focus, the health of doctors during the pandemic. We know that although doctors were at increased risk for acquiring the infection, it became increasingly concerning that doctors may have been at increased risk of the most serious outcomes of the infection, such as that of hospitalization and death. And so some of the studies that have begun to emerge have clearly started to show that health professionals generally, and doctors in particular, may be at particular risk for these adverse outcomes. This UK study here of over 120,000 biobank cohort participants showed this quite clearly. When we looked at healthcare workers generally, there was over a 7-fold increase of risk for hospitalization in these workers when compared to non-essential workers. However, when you looked at healthcare professionals within the sample of healthcare workers generally, this increased to almost 9-fold. So doctors and nurses were more than 9 times more likely to have a more severe outcome of COVID-19. And this, if you look at Model 6, it adjusts for all the usual vulnerable factors. So notwithstanding the vulnerability criteria, doctors and nurses were at greater risk for this. We saw similar sorts of statistics in the South African data. Although our South African data has not yet been well analyzed, particularly for healthcare professionals, colleagues looked at the DATCOV data, which is hospitalization data for people with COVID-19. And what they found that approximately up to the end of the second wave, approximately 4% of those that were hospitalized were healthcare workers. And this shows as well that in the 2 waves that we experienced up to the early part of this year, the numbers of doctors or healthcare professionals in the first wave constituted approximately 5% of hospital admissions. This had come down by the second wave to approximately 2.5%. The reasons for why this may have come down could be initially that healthcare workers will less experienced in the way they approach the infection, less careful about their protective gear, and as the epidemic unfolded, their ability to protect themselves improved. However, it's not clear as to why healthcare professionals have an increased risk of the most serious outcomes. But we know that COVID-19 is not just an infection. And particularly for doctors, long COVID is of a serious concern. More so because this is so poorly documented among healthcare workers generally, but particularly amongst doctors. And apart from long COVID, we know that the infection and its consequences have given rise to a whole range of mental health outcomes. And these, you know more about these than I do, being on the front line and experience these on a daily basis. But working as as a doctor, it's not just about being exposed to infections. And although the SARS-CoV-2 virus brought into sharp focus the consequences of workplace exposures, we still tend to be more focused on infection. But this does provide us with an opportunity to try to understand better how workplace exposures are likely to impact on the health of doctors. What we need to do is to use the principles of occupational health and find the tools that will help us protect ourselves, not just from biohazards such as the SARS-CoV-2 virus, but also other exposures in the workplace. So, using occupational health principles, the first thing that we need to do is to understand what are the hazards that we find in our workplace. Bearing in mind that not every hazard is a risk. For example, a beaker of sulfuric acid in a closed cupboard is a hazard, but does not pose a risk until that chemical is removed from that particular cupboard. So what we need to do is, having identified the hazards, we then need to understand what is the level of risk that is posed by these hazards in our specific workplaces. Recognizing that doctors work in different working environments, in different contexts, and the risks even among doctors will vary all the time. So it's important that these sorts of assessments of risk are individualized to the different workplaces. Given that we've identified risks in specific places, we then need to focus on how do we control these risks, how do we control the hazard to ensure that it does not become a risk. In other words, keep that bottle of sulfuric acid in the cupboard for as long as we can. Because we know that if we don't appropriately control the hazard, it is going to result in health outcomes. And so that's what we want to try to understand today. So when we in occupational health and in occupational medicine in particular try to understand the hazards that we face in different workplaces, we try to categorize them into one of 6 different categories. I'm not going to go through all of these because some of them will be pretty obvious to all of you, but to pick on a few to highlight some of these as examples. First one, obviously in a healthcare setting, is that of the biological hazards. And we know this all the time. But there are different types of biological hazards. We have those that are spread through the air. We have those that are spread through bloodborne, through blood contact or of any other biological sample contact, as well as the direct contact agents. Understanding these 3 different categories, understanding the type of biological agent and how it is spread, gives us a better opportunity to understand how they pose a risk and how we control it. Similarly, if we look at physical hazards, we know that doctors in nuclear medicine and our radiologists well understand the risks of radiation and take steps to protect themselves. But you may ask, in the healthcare setting, where do we have noise? And how can noise present with such a sufficient level that it will become a cause adverse health outcomes? I'll show you some studies that have been done on this in a short while. And then for those workers working in laboratories particularly, temperature extremes, working in extremely cold or extremely hot environments becomes an issue. Clearly, the most important and probably the one that we as doctors concern ourselves least is that of chemical hazards. And as you can see in the list that I've got there, this is only a partial category of types of chemicals that we find in healthcare settings, and doctors are exposed to this at different levels depending on the types of work that they do. We do know that our anesthetic colleagues are probably the most aware when it comes to health and safety because of the types of agents that they're exposed to and their ability to look for ways in which they can better control this. But some of the other agents that we're exposed to are less well controlled and therefore pose a risk to the workers, to the doctors that are exposed to these. So those are the hazards that we find. The next question is, yes, we know that these are hazards, but, you know, I don't know of any stories of workers becoming sick or doctors becoming sick because of these exposures. The question then we have to ask ourselves, given those hazards that we face in our workplace, do they pose a risk? In order for a hazard that we find in our workplace to pose a risk, there's got to be exposure to that particular hazard. We've got to understand the mechanism or the pathway in which that hazard results in exposure. If you have a hazard, if you're exposed to a hazard, there's a potential for risk. That risk will vary depending on how you're exposed to it, and we'll explore that in a short while. But also, very importantly, not everybody who is exposed to a hazard is likely to have a health outcome. So there may be individuals who are particularly vulnerable to that exposure. And we know this with a very common example in the healthcare setting, the use of latex gloves. At least now we've mostly replaced the allergenic gloves with hypoallergenic latex gloves. But we do know that not everybody who's used latex gloves developed dermatitis. Okay. So certainly there are certain individuals exposed to this particular hazard who are at greater risk for developing this health outcome. So in order for us to understand this, we've got to conduct a risk assessment. And we've got to conduct, as you can see, because hazards and exposures will vary across different clinical practices. We've got to conduct these in the various places where we do have these exposures. What we do when we conduct a risk assessment, we try to understand the likelihood of exposure, and we then also determine the severity or the consequence of that particular exposure. And by trying to understand these two different criteria, we create a risk matrix as shown on the slide here. And if the exposure is very likely and the consequence is extremely serious, then one will rate this as an intolerable risk. As you can see in the bottom end of the slide, showing you this red block. And based on that, we make determinations about how we control the hazard, how much of resources do we need to invest in controlling a particular hazard. So if the hazard presents with an intolerable risk, then obviously we have to throw vast amount of resources to ensure that we do control it and we do prevent people from becoming ill. And if it's less likely, then and the risk is small, we adopt a different approach to that control. Right, so what we've seen so far is that we've got a hazard to which we are exposed, and if we're exposed to it sufficiently, it could pose a risk. Now, the risk that we're most concerned with in this talk anyway is occupational diseases. There have been lots of studies which have shown fairly substantive health outcomes amongst doctors, and these are for the more common conditions which all of you may have experienced from time to time and are fairly familiar with. Psychosocial disorders, like I've described under COVID-19, musculoskeletal disorders, your sharps injuries, and violence in the workplace, particularly in your trauma units, etc. And then, of course, infectious diseases. However, for other occupational diseases, there's less consistent data and fewer studies have been conducted among doctors. And these are for your allergic diseases, your work-related asthma, cancers, and reproductive outcomes. There's obviously a much longer list, but these are some of the ones that we need to be concerned about. And the reason for this is because we have so few studies being conducted amongst doctors as a group. You have lots of studies that have been conducted amongst healthcare workers generally, but these tend not to focus on doctors. We'll come to discussing the reasons why that may be the case. But let's look at some of the examples of exposures in a clinical practice that may result in adverse health outcomes. As I mentioned, I think our anesthetic colleagues are probably way ahead of most of us in terms of protecting their health from adverse outcomes. But this is just one study, albeit an old study, but it shows you the risk that doctors face. So here we have female workers in hospitals exposed to anesthetic gases. And these females had almost a twofold increase in risk for spontaneous abortion. But it's not just the female worker that was affected. If male workers were exposed to these anesthetic gases, they had their spouses had almost a 2.3-fold increase risk of spontaneous abortions. So the workplace exposures can get transferred into a home setting. And this is so important to understand. It's not just you as the worker being exposed, but the extent to which you can carry this exposure home to your family. Another example of exposures that are likely to cause workplace diseases in clinical practice is surgical smoke. Now, it's been a while since I've been in clinical settings where this sort of exposure is practiced, but I'm pretty sure that the practice has not changed much. So from the evidence that we have, surgical smoke consists of a whole range of pollutants that are likely to cause adverse health outcomes. Toxic gases, which include carcinogens, agents that are likely to cause reproductive disorders, are in substantial amounts, substantial concentrations in these sorts of exposures. The National Institute for Occupational Safety and Health in the US has estimated that over 1.5 million healthcare workers are exposed to this each year. Challenge for us is being able to say that this exposure is likely to result in an adverse outcome. There have been case studies, and there have been some studies which have indicated that doctors are likely to be exposed to higher levels of exposure. However, the ability to translate these sorts of studies into larger epidemiological studies, to be able to say conclusively that surgical smoke creates these sorts of outcomes, is a major challenge. And once again, I'll speak about why these are challenges in the medical setting. Aerosolized medication is probably in the era of the pandemic being increasingly used. And this is some of the outcomes. Respiratory therapists who were exposed to this form of medication were almost 8 times more likely to be diagnosed with asthma after they've started work. And I've put an insert there of the types of outcomes that are likely to be associated with the use of this medication. I'm not sure to what extent these are used in South Africa, but clearly the outcomes of reproductive effects, kidney toxicity, and respiratory effects are certainly causes for us to be concerned about the impacts that this would have on medical practitioners. So there's a whole range of other diseases that are likely to be associated with workplace exposure. I spoke about noise earlier on, and one wonders how doctors will have noise-related outcomes. But in this study, done amongst orthopedic staff, you see here that consultants doing bone surgery have an increased risk of developing noise-induced hearing loss. In the study, definitely a very small study with 27 subjects, of which 16 were actual medical consultants, 50% of them had documented noise-induced hearing loss because of these exposures. If you look at some of the studies around cancers, in this a French study where they looked at about 1,000 doctors generally, and they compared them to the general population around that teaching hospital. Generally, cancer risk was not increased except for hematological cancers, almost a five-fold or more than a five-fold statistically significant increase when compared to the local population. So clearly, doctors are at increased risk for developing these outcomes when we're able to do these proper epidemiological studies. But, as I said, we know what exposures doctors experience, but we've not been able to characterize the risk adequately. Similarly, for the exposures that doctors experience, we've not been able to properly define the exposure-outcome relationships. And there's a number of reasons for this. Firstly, doctors are not very good participants in epidemiological studies. So in the 1950s, when Richard Dole described the effects of smoking and lung cancer, this study was done amongst the British doctors. Since then, large epidemiological studies, cohort studies amongst doctors have been probably almost non-existent, particularly to understand workplace exposures and occupational diseases. The other challenge is that the doctors work in small or individual practices. Trying to characterize exposure in these settings is extremely difficult, and from an epidemiological point of view, a major challenge. So for all of these reasons, we're not able to properly characterize the risk, and we're not able to properly determine the epidemiological outcome. We're therefore forced to rely on precautionary principles. So having conducted a risk assessment, which we can do in every workplace, and medical practitioners can use a sort of rational approach in understanding the risk and conducting risk assessments. If you determine that you are likely to be exposed to a higher level of a particular pollutant, a particular exposure, then use precautionary principles to protect yourselves. And once again, I refer to the principles and tools that we have in occupational health. So, what have we done so far? We determined that in large numbers of medical clinical practices, there are hazards which need to be controlled. We need to know what are the levels of risk posed by these hazards that we see in these workplaces. Excuse me. The next step is we've discussed the health outcomes associated with these exposures. What I want to do now is to go back a step and look at how we control these hazards. And in the context of COVID-19, this has come to the fore, where we speak about a whole range of controlling of exposures, controlling of hazards, and the use of PPE. So once again, another principle in occupational health. We speak about a hierarchy of controls. What is the best method to control, and what is the least effective method of control? And this, thankfully, is stipulated in South African legislation. South African legislation places a considerable amount of emphasis on the hierarchy of controls and advises that as far as possible, we work on eliminating the hazard. And as you can see here, it's the top part of this inverted pyramid. We remove the hazard. If we're not able to do this, then we look at replacing the hazard. For example, latex gloves was seen as being a problem in that it caused vast numbers of healthcare workers to become allergic. We're not able to replace gloves. Gloves are an essential tool in clinical practice. So the step was to look at replacing the hazard with something less hazardous. As a result, now we have latex-free or hypoallergenic gloves. And what we like to do, if we're not able to eliminate or substitute, is to look at how we can control using engineering means to prevent people from being exposed. But this generally doesn't work. And as we know, that when we look at the pandemic, the two most important methods of controlling our exposure was the use of PPE and administrative controls. And as I said to you, the South African legislation, the Hazardous Chemical Agents Regulations under the Occupational Safety and Health Act clearly stipulates that this PPE is the last step. You only use PPE when you've shown the other steps are not reasonably practical. But clearly in a clinical setting, we tend to resort to PPE and administrative controls more frequently than we would with elimination, substitution, and engineering. And this is because we're working with people. People bring in the virus to us. There's no way you can eliminate or substitute that unless you start thinking about methods of telemedicine and those means. But the best that we have now is the use of PPE. But let's talk about ventilation, because this also became quite a big issue in the epidemic. We talk about the use of ventilation in clinical practice, and essentially what we're talking about here is how do we control exposures to vapors, gases, aerosols, and particles. And this debate about is the COVID-19, is the SARS-CoV-2 virus a particle or an aerosol? Because this starts to influence how we manage and how we control the virus. The big debate was, is this just a short-range transmission? In other words, do we need to focus just on the non-therapeutic interventions that we've spoken about so extensively, which is use of a mask and social distancing, or is long-range transmission possible? A number of agencies, WHO and the US CDC, have concluded that yes, long-range transmission of the virus is possible, particularly in places where it's enclosed with inadequate ventilation, where you have situations of increased exhalation, for example, people singing in a choir, people coughing, and people sneezing. This would result in a longer spread of the virus particles. And then you have prolonged exposure in various settings. To address this, the Occupational Health and Safety work stream within the National Department of Health, which has been responsible for the issuing of several guidelines over the last year and a half around the virus, has just released its guidelines for ventilation, and this will be circulated to all parties in the next few days. So what is ventilation? Ventilation is defined as the process by which air is intentionally provided to or extracted from an indoor space for the purposes of diluting or removing indoor contaminants. So that's quite key. It's an intention to make sure that we reduce the risk of the indoor contaminants. And as I indicated, these indoor contaminants could be gases, vapors, particles, etc. What must be emphasized that ventilation is not air conditioning. If you have an air conditioner in your clinical practice, that does not automatically mean your practice is well ventilated. Most ventilation systems do not bring in the outdoor air, and unless you're certain that it does, then you need to make sure that your systems are bringing in clean air and diluting the contaminated air that you have indoors. So the question is then, how do we know in the environment that we're working in, that we're sitting in, that we have adequate ventilation? In the absence of doing any objective measurements, it's personal comfort. So you're sitting in a hall of, in a room of 50 people. How well are you feeling? Do you think it's stuffy? Do you think it's getting a little bit too warm? those could be indicators that the ventilation is not adequate. What we'd like to see that in any environment that your CO2 levels, your carbon dioxide levels, does not go beyond 800 parts per million. And if it does, then you have inadequate ventilation. For healthcare facilities, we speak about air changes per hour. And depending on the type of environment you're working in a healthcare setting, this can range from 6 to 12 air changes per hour. In other words, the entire volume of air in that particular room must be exchanged at least 6 times to 12 times. Certainly in all clinical settings where there is a likelihood of a biohazard, then you want to see at least 12 changes per hour. The pictures, graphics on the right, one is a CO2 monitor and the other is a air change anemometer, which tells you how many air changes you have per hour, and you use these to calculate whether the air changes are adequate in your practice. The WHO has stipulated that for the SARS-CoV-2 virus, you need a minimum of 10 liters per second per person in that room of air for every person in the room. Sorry, 10 liters per second for every person that is in that room. There are 2 types of ventilation that we speak about, natural and mechanical. Clearly, we'd like to emphasize that natural ventilation is the best way because it's the cheapest and most controllable. We want to see, so you have different types of natural ventilation, single side or cross ventilation. Clearly, in most settings, the cross ventilation is the most appropriate. But in other settings, such as your aerosol generating procedure rooms, you want to have much more control over the ventilation. And so you may have the establishment of ante-rooms and double doors to protect yourselves. The WHO has prescribed a roadmap to how we should improve ventilation, but the best approach is if you're not using natural ventilation and you're not satisfied with this achieving the air exchange that you require, then you need to bring in your experts to start talking to you about mechanical ventilation. If natural ventilation doesn't meet these standards, then we need to look at other options. You could look at almost as a stopgap measure is mobile cleaners with what we refer to as high efficiency particulate air filters. These are, once again, even if you're having these, then it has to be done in consultation with the necessary experts. Depending on the type of environment you have, for example, if you're working with chemicals, you're working in an aerosol generating area, then you need to start thinking about what sorts of extraction ventilation you need to install in your environment. And as I said, surgical smoke is a major issue. And if you are working in a setting where you are using these, then we need to speak about local exhaust ventilations and suction units within the breathing zone of the operator. And this is clearly, if a person is working with these instruments, it's no point in putting a extraction ventilation or window behind the operator, because then the pollutant is with the breathing zone of the operator is within the pathway of the pollutant emission and the extraction window or mechanism that you may have in place. Another issue that has come to the fore, particularly during the period of the pandemic, has been that of ultraviolet light. Now, we know that for many years that ultraviolet C-band is established germicide agent, and it has been used in many healthcare settings. However, the CDC in the US as well as the WHO at this point in time is not happy with the level of evidence for the SARS-CoV-2 virus itself. Although it's been shown to be effective against other coronaviruses, the evidence for the SARS-CoV-2 virus is just not there yet. And part of the reason is that the challenges in actually using UVC light for controlling of or disinfection of the virus. Firstly, it requires direct exposure, and it requires a specific dose. Now, even though we speak about the C-band, the C-band it covers a broad wavelength, and commercial labs, because they want to err on the side of safety, may not meet this particular wavelength that results in germicidal effect. So getting commercial UVC lamps may not be most appropriate. And there are a wide range of risks associated with this, particularly things like blindness or other eye problems, as well as skin disorders. What has been shown, however, is that this can be used for the upper room air and air handling units as a supplemental measure to control air disinfection. And the image on the right shows this. You need this to be placed at least 2.1 meters above the ground level, with the light shining towards the ceiling and not downwards towards the people that may be in the room. UV lighting is not recommended for surface cleaning. Under controlled conditions, it may be used for PPE disinfection, but once again, it has to be done on the basis of advice from an expert. So it's not a question of using commercially available products. You've got to make sure that this is appropriate for the germicidal range in terms of the wavelength. So finally, I just want to speak very briefly about personal protective equipment. For us in occupational health, we were quite pleased to see the way people approached the pandemic and basically trying to understand principles of occupational health in addressing the control of the hazard and protection of people. But we also saw that because people were not adequately trained in understanding these different approaches, that it led to more problems thereafter. So the first principle about personal protective equipment is that by definition, it protects the user from the environment. So I'll speak about this just now as to why I'm emphasizing this. But also, as I said, in terms of our legislation and in terms of our understanding, PPE is the least effective and must be the last line in controlling exposure. We've got to be able to show that all other means of controlling exposure has failed and you're therefore resorting to PPE. When you choose PPE, you must have evidence that it reduces exposure. And we saw this. If you take the discussions that we've had around mask usage. Do you use a N95 mask? Do you use an N99 mask? Do you use a FFP1, FFP3 mask? So all of these have different levels in which they will reduce exposure to the virus particles. And because of this, we then need to make sure that we're using the appropriate equipment at appropriate time. Other principles are that you've got to make sure that you have a correct selection, the appropriate use and training, cleaning and storage. Now, when we look at how the epidemic unfolded, we saw large numbers of people insisting on the use of PPE, and basically everybody became an expert in the use of PPE. Unfortunately, people were not appropriately trained, and therefore we had challenges with the correct selection and the correct use at different points in time. But these are legal expectations of the employer. Under our hazardous chemical substances, chemical agents regulations, hazardous biological agents regulations, the employer is expected to provide these sorts of equipment if all other means of controlling the hazard is failed. Also, making sure that if you are using PPE, it gets properly disposed of. PPE ought not to be taken home. It ought not to be used in any other settings except in the workplace. And therefore, at the workplace, there's got to be a proper procedure defined as to how these get disposed of. In the context of the epidemic, and I want to emphasize this, as I said, PPE protects the user from the environment. So although the cloth mask is a legal requirement under the Disaster Management Act and the consequent regulations, and a surgical mask is also a stipulated requirement under the directions from the Department of Employment and Labor, both of these are not personal protective equipment. Neither of these two protect the user from the environment. In both instances, these protect the environment from the user. And that distinction has got to be made quite clear in the epidemic, because people often think, well, I'm using a cloth mask or I'm using a surgical mask and therefore I'm protected. This is not the case. In studies that have been done with surgical masks, anything between 20% to 80% of particles may pass through a surgical mask. And that's because it is not a PPE. It is not fit tested, and it is not intended to protect the user from exposures that they may have in the working environment. So finally, in summary, I'd like to emphasize that doctors in clinical practice are exposed to a range of hazards that are likely to result in adverse health outcomes. Doctors' practices vary considerably, and you cannot make assumptions about a sort of one glove fits all approach. You've got to conduct risk assessments to determine whether the exposures that are experienced in your workplace are likely to create problems. If you do, then you need to identify measures to reduce the risk, and where possible, you want to look at engineering controls if this is reasonably practical. And what we tend not to do is we don't monitor the health of workers. So we ask, but yeah, I work with this agent all the time, but I've not had any problems. Possibly you've not, but there may be subclinical effects that you do not pick up until you've long since left that particular working area. Because doctors are likely to have problems, and this is distributed across a wide network, we're not able to do the epidemiological studies to show the definitive increase in risk. But we need to put into place methods to ensure that we're monitoring the health of workers, monitoring the health of doctors based on the exposures that they experience in the workplace. I once again thank the organizers, and I thank you for your participation in this talk. I look forward to having discussions with you after this. Thank you very much.
Thank you very much, Prof. Such a thought-provoking lecture there. From the audience, I think you've seen that on the chat we've posted some interesting questions just to try and engage with you, and just to get a sense of are we doing the right things, specifically speaking to occupational health. And I'll revert some questions that I'm seeing on the chat to Prof to basically address. I like the last part, Prof, where you start talking about PPE. And for me, I was, watching our colleagues last year, and it was interesting how COVID has actually exposed our knowledge as clinicians on how we use PPE and the importance of ventilation in our ICUs, the importance of ventilation in our clinic setups, and how we really, go past all those charts that are plugged in our A&E, in our wards. And, those are documents that speaks to our safety and what we should be, our conduct in the wards and when we're dealing with our patients. So I think the first question that goes to the audience, I'm not sure whether we've got some answers, is apart from infections, how many doctors have experienced work-related illnesses? I'm not sure if we got some replies there. And then secondly, I think it's a very interesting one, that is doctors who employ others, have they ever considered the legal obligations under the Occupational Health and Safety Act of Compensation Act. So if there are any answers there, and Prof will possibly address his point of view for those two questions.
Thanks, Lima. So while we're waiting, I see Prof. Naidu has posted a question here on commenting on the K95 masks that have flooded the market and have been extensively used. So I think this has been an issue that has really troubled healthcare workers in the last year. I think it's very important. So just as we all are very familiar with the N95 and the N99 masks and the FFP categorization, these are all classification systems. So the N system is used in the United States, the FFP system is used in Europe and the UK, and the KN system is used in Asia mostly. And these basically speak to the levels of protection that that particular equipment will provide. People have been concerned because quite obviously what was happening during the epidemic was that there have been some fraudulent use of these classification systems. And we know that this can happen across the board. So, you know, we had masks that were coming in, not just to South Africa, but to different parts of the world. Even in the US, they had to scrap, you know, literally millions of masks because even though they had the stamp of approval saying that this was a N95 mask, it was subsequently turned out to be false or fraudulently marked. And so it's not the rating. The KN95 masks themselves are equivalent to a N95 or a FFP3 mask. Well, a FFP3 mask is a little bit better than the N95 or the KN95, but they're in the same sort of range. But obviously, you need to make sure that the company that has manufactured that mask is a legitimate company, that mask is a genuine KN95 mask.
Okay, I appreciate that, Prof. And while we're still waiting for responses, it's a very interesting one, especially the question where we look at doctors who employ others. And if people have never considered this, what is the risk? What is the risk they're putting their practice, or as the owner of their practice, what risk are they putting themselves in if they have never considered it and have actually not, put systems in place to address these issues?
So this is quite important, and I must admit I didn't pay much attention in the presentation on this, that doctors themselves can be employers. And in that sort of setting, they have to make sure that they adhere to the Occupational Health and Safety Act and its regulations. This means that they, in their practices, are obliged to conduct a health risk assessment. They're obliged to ensure that they're controlling hazards. And if anybody becomes ill as a result of their exposures in the workplace, then they've got to report this to the Department of Labor. And often we as doctors tend to forget that we have responsibilities to our fellow staff members. I didn't focus much on the issue around compensation of doctors with occupational diseases, and we could see if questions around that comes through. But this is largely because doctors in the private sector are self-employed, they won't qualify for compensation under our compensation system. Our compensation system only supports employees. So doctors who are self-employed won't qualify, but certainly their staff members will. Their employees will.
Okay, that's a very interesting one. So, Prof, now for someone who's starting off, opening a practice, how do they go about at least having an informal assessment or risk assessment of their practice? Obviously, there's lots of challenges, and this is, as I have said, I think it's a field where we've got limited knowledge. Where do we knock? Who do we call for this informal risk assessment that should trouble happen in my practice? At least I have some documentation that I had an interest to do this, but I had some limitations.
Okay, so all the doctors should go and get postgraduate diplomas in occupational health. but that aside from that. So the one of the affiliated organizations to SAMA, the South African Society for Occupational Medicine, has a whole range of guideline documents that provides doctors and provides other health professionals with some approaches about how they should conduct the issues around health and safety in their working environments. If you think that your particular environment or your particular working activities is a little bit more complex, where, for example, you're either generating, having extensive aerosol generating procedures and you're going to require ventilation, etc., then for those, I would suggest that you start to bring in more experts. If for whatever reason you're operating a laboratory setting, then obviously you're working with a whole range of chemicals. For that, you need to conduct formal risk assessments as per our legislation.
Okay, I see, Prof. We still don't have any questions. I'm not sure whether we have any comments from the general pool of audience. We have 10 minutes left. I'm not sure, is there any issue that you want to address, Prof, that you think is pertinent that we should know?
And so, I mean, there's a lot of information that I presented in the slides, and some of them we didn't get through in substantial detail. But for me, it's critical that doctors understand that they are exposed to hazards, and they've got to understand that this is likely to cause ill health, and they've got to be able to understand how they control these. Often doctors, we all do this, we're so caught up in the work that we do, we're so caught up in protecting the health of others that we forget that we ourselves are likely to be at risk. And we became extremely concerned with the virus because, the exposure and the outcome was a very short time frame. Whereas if you're exposed to anesthetic gases, you're exposed to other chemicals, the outcome takes place months to years later. And as a result of that, we tend not to make the association between the exposure and the outcome. And therefore, we don't pay as much attention to controlling that exposure. So that's why it's important that we understand the risks and we look at ways in which we can control them. There's a question from Dr. Hussain about double surgical masks and how to use them. I think in conditions with PPE shortage, then use of things like double surgical masks could be suggested. But once again, to point out, double surgical masking or surgical masks themselves are not protective equipment. So because the particles that are prevented from passing through that surgical mask is not small enough to for you to inhale, then the chances that you're going to prevent the virus from traversing that mask is very low. I don't know what the research would say about use of a double mask and whether the double mask will actually prevent the virus from transgressing the mask and allowing you to inhale the particle. But I would be very reluctant to advise that unless your conditions are extreme and you don't have proper PPE.
Okay. We've got a couple of questions popping through, Prof. So here's one. It says, I see healthcare workers in the hospital, occupational healthcare clinic, post-COVID as part of return to work assessment. I complete the first medical and the final medical report. Are these workers going to be compensated for having COVID?
So with our compensation system, compensation for COVID is if you have any function. Firstly, you will get compensated for short-term disability. In other words, if you're away from work for a particular period of time, you would get your full income, or you'll get a percentage of your income and any other medical aid benefits that you require to treat yourself for the COVID. So for example, if you get admitted to hospital, those costs do not need to arise from your medical aid, but they're covered by the compensation system. if you can show that you have long COVID or you have persistent symptoms associated with the original infection, then the commissioner, a compensation commissioner, is obliged to provide you with benefits based on the level of functional impairment that you may have. So, for example, because you're possibly not able to work in, say, for example, in an operating theater, but you're a surgeon and your job has to be changed, then you could be compensated for that that level of impairment. But it's essentially a functional impairment that the commissioner will decide upon.
Okay, thank you, Prof. Just a couple of questions. We only have 5 minutes, so we'll probably address one or two. How can employers self-insure privately for occupational diseases and the effects on their ability to work? Do you have a comment on that?
So I'm assuming that that this question is for doctors in the private setting where they're both working and they're also self-employed. So essentially, you would have to then look for getting your private insurance, and largely things like your PPS and any other sources will be covered based on the type of personal insurance that you take out. You cannot be covered under the Compensation Act.
Okay. Prof, let me test whether how biased are you regarding occupational health. What's your take on ensuring the 6-year program or our medical program incorporates more of occupational health? Because I think we're faced with clinical students in their final years and also interns that have no clue as to how they're supposed to conduct themselves in work areas, particularly to infectious disease, and how to go around carrying themselves in our workplaces. Do you have something to say regarding our curriculum? Do we need to beef it up, or should we all just go for a postgraduate diploma, since most of us have missed it?
Yeah, so you're opening up a can of worms there, particularly with me. Yes, I think, about 10 years ago, when I started out in occupational medicine at our medical school at UKZN, we were spending a considerable amount of time at first and second years with in terms of occupational health and teaching them about understanding workplaces. We sent out our undergraduates to factories to understand exposures, because until you get out into a factory, you really don't know how workers are exposed. So I think at the moment, we do some lectures in the first year, and the poor students are quite baffled by what we say, because they're not really, they've come there now as bright-eyed students to learn about illnesses, and here we're telling them about workplaces. And that's about all that we do. Then we cover, I think, 1 or 2 more lectures in the subsequent 4 years, and we set them out into the real world to treat large numbers of workers. So I think it's currently our curriculum is considerably inadequate, and it certainly needs to be addressed. I think postgraduate diploma programs are particularly useful for those that are looking at working in the sector, and for those that may have a family practice that is located in an industrial setting. We often see this where doctors are located in an industrial area and they're seeing large numbers of workers. And for those doctors, it is useful for them to consider getting trained at a postgraduate level.
Prof, thank you very much for your time. I hope you have a great Sunday going forward.
Thank you very much to the organizers, and hopefully I will be able to answer some of the other questions that have been posted on the chat by email and sent through to Sama. Thank you very much for the opportunity.
Yes, I will appreciate that. Thanks, Prof. And we've come to the end of our session. And firstly, I would like to thank all the presenters, and also to thank the delegates actually for joining us and making this a successful conference. I would also like to thank the SAMA, especially the EST committee led by Prof. Naidu, to actually plan such a very intriguing and also informative conference in light of the COVID, and also being on a virtual platform. It's been an interesting one. We appreciate it. And our host, I think, ICE Productions, for such a very comprehensive and, well, quite high-tech virtual conference, and the amount of work they've done in the background. But before you leave, like I said before, please do help us by taking a quick poll, as this will assist us in generating your CPD certificate that you actually find in our website. So we do value your personal feedback, and we appreciate that you've taken time not to attend your church services and also not to attend the beautiful weather for those who are in Cape Town. Have a great Sunday, and thank you very much.